The Epilepsy Innovation Conference is designed to showcase the latest advancements in the field of epilepsy and exciting developments that are on the horizon for people with epilepsy. Our incredible opening speaker will do exactly that today. I am so pleased to introduce Dr. David Burdette, epileptologist at Spectrum Health. I know that he is well known to many of you. For some of you, he is your epileptologist. And to all of us, he is a great friend and supporter at the Epilepsy Foundation of Michigan, serving as one of our professional advisory council members. So with gratitude, presenting today on research pipeline, innovations in epilepsy treatments and therapies, I am honored to welcome Dr. David Burdette. Thank you.
Hello, everyone. In our virtual world, I hope that you can hear me. I will trust that you can. So I'm David Burdette, and it is absolutely my pleasure to be able to join you today to talk about some of the exciting advances that we have seen in the world of epilepsy, specifically in our understanding of epileptic seizures and in the evaluation and treatment of epileptic seizures. Today, you're going to hear from an impressive array of epilepsy specialists, advocates, and patients. And this will ideally be a very informative and frankly exciting conference just to see the progress that is being made. For the next hour or a little less, I would like to discuss some innovations. And these innovations are going to cross a vast array of areas within epilepsy. We'll talk about some of our basic treatments, but some of the newer angles, if you will, within the world, say, of anti-seizure medications. We'll talk a little bit about surgical evaluations. We'll talk a little bit about neuromodulation, a word that I am increasingly excited about. And lastly, we will end with a notion about trending, that our current technologies give us an overview of the overall cycle of epilepsy. Before I jump in and talk about these multiple moving parts, let's establish a baseline. As we know, epilepsy is a network disorder, and we have a number of data points that support this notion, not the least of which is that if someone has their typical seizure, and let's say hypothetically, we are recording that seizure from within the brain, every seizure they have is going to be a variation of the previous one. And these are very stereotyped. So seizure to seizure to seizure, the network that is generating those seizures will look incredibly similar. We also know that, for instance, if someone has a focal type seizure disorder, so the seizure starts in a network in one hemisphere of the brain or the other, that if it spreads, it will spread in a very stereotyped fashion, consistent with a network. What do I mean by a network? This is an oversimplification, but frankly is a model that we can work with, where we have a series of nerve cells, a series of neurons, each of which is exciting the next one. And in this network of excitation, we have a brake, if you will, like the brakes on a car, built into the system. So if that network gets going, then we can put the brakes on and slow that network down. If a situation arises during which the level of excitation exceeds the ability of those brakes to slow down that network, then a seizure will occur. And that seizure doesn't occur in a vacuum. It isn't just this one simple network. It is connected to millions of neighboring neurons. And so this seizure onset zone, if you will, gets going, and then it tries to entrain the firing of its neighbors. If it succeeds, then the seizure spreads, and it may spread more and more. So today, what I would like to discuss are a few anti-seizure medications that we use to treat various forms of epilepsy. So first, let's start with one of the most common forms of epilepsy, which is focal epilepsy, seizures starting from a network in one half of the brain, in one hemisphere of the brain. When we think of seizures, we must compare it to a baseline. And at a baseline, we are doing our thing. We are thinking our lofty thoughts. We are interacting. We are part of the social network in which we exist. If, however, that little pesky network takes off and begins to develop a life of its own, then a seizure starts. And that seizure may spread. So when it starts, oftentimes there is no impairment of our awareness, and we may or may not even be aware that a seizure is occurring. So we would call that a focal aware seizure. If it spreads to the memory forming parts of the brain, then we lose awareness of our surroundings, or at least have impairment of our alertness, awareness. So we call that a focal impaired awareness seizure. And God forbid it spreads to the entire brain, in which case we have a focal to bilateral tonic-clonic seizure. What we in years past might have called a grand mal seizure, and more recently, a secondarily generalized tonic-clonic seizure. Now the current terminology in this setting, where it starts focally and spreads to the entire brain, is focal to bilateral tonic-clonic seizure. If we have this little pesky network that wants to develop a life of its own, what keeps it from always developing a life of its own? What keeps it in check? Well, in a sense, the brain knows that it's not supposed to be doing it that. So it controls that area to try to keep it in check. And there's this constant push and pull. The network that is overactive is trying to push us down toward a more severe seizure, and the brain itself is pushing back and trying to control that area. And this leads us to our first category of treatment, which is anti-seizure medications. These medications are designed to augment the ability of the brain to fight off a seizure. So in this space, we have many medications. Over 25 medications are FDA approved for the chronic daily treatment of epilepsy. In the realm of innovations, we have one medication that is relatively new, and this medication is cenobamate. I see a lot of lines here. So what the heck is this about? Well, in the left-hand side, the A, if you will, graph, we want those lines to go down. We want seizures to go down. And we see that in the drug trials for cenobamate, that the upper line that didn't go down as much was the placebo group. Interestingly, in an anti-seizure medication trial, some of you may have participated in such trials. Oftentimes, the majority of people, whether they got randomized to getting a placebo or randomized to getting the medication do better. The reason that the placebo group does better is not that a sugar pill, so to speak, will make your seizures better, but rather when you are part of an anti-seizure medication trial, you tend to be very attentive to making sure you get those medications taken on time. And the people who are running the trial are very attentive to assure that all life events, that all medication and other related events are set up in your favor. The long and the short of it with this trial is that there is a subset of people represented by this red line who did particularly well. And in short, 100 milligrams of cenobamate was better than taking a placebo. 200 was more impressive over placebo, and 400 milligrams a day was the most robust response. So we like to see this with anti-seizure medications, where a little bit of medication makes you a little bit better, and more medication makes you a lot better. The flip side of that is that a person may, when they're on more medication, have side effects. So ultimately, our goal is we want your seizures controlled. We want you to be a seizure-free zone on the least amount of fewest medications possible. The most common side effects that were seen with cenobamate were sleepiness and dizziness, and there was some headache. Oftentimes that headache is driven by post-seizure headache. It's not uncommon, as you likely know, to get a migraine headache following a seizure. With regard to the other two side effects, sleepiness and dizziness, almost, I would say, regardless of the medication, those are the two most common side effects. There were 3 patients who had what would be termed an allergic reaction or a hypersensitivity reaction, and we minimize that risk by starting low and going slow. So this is not a medication that we're going to get you up to speed. This is a medication we're going to start at a low dose and increase it. So that is our latest innovation in the anti-seizure medication for the treatment of focal epilepsy front. Now let's up the ante. Let's talk about perhaps a little more severe epilepsy, where instead of having a discrete network in one part of the brain that is causing problems, now we have networks in multiple areas of the brain. And as you can imagine, there's going to be a complex interaction between these networks, and this is going to make for a more difficult to treat form of epilepsy. There are 2 of these forms that are most well characterized. One is a notion of Lennox-Gastaut syndrome. Lennox-Gastaut syndrome is characterized by multiple seizure types, and these seizures tend to be what we call refractory. They are not responsive to any combination of anti-seizure medication. Additionally, when you have this many networks in your brain, it's going to slow you down on the cognitive front. It's going to be harder to concentrate, harder to remember. So we're going to have an element of cognitive slowing. And then lastly, there are going to be some characteristic findings on that test that we know and love, the EEG. Lennox-Gastaut syndrome appears in childhood, but persists into adulthood, and is, as I mentioned, a particularly difficult to treat form of epilepsy. There is also a genetic form of epilepsy that was characterized by Charlotte Devries in France, and is related to a mutation of the sodium channels, the SCN1A, and in some cases 1B. And these individuals have normal development until they are a few months old, and then often in the setting of an infection, a fever, or even a mild increase in body temperature, it can trigger the expression of Dravet syndrome, where these individuals will have incredibly difficult and rather scary seizures that some of our anti-seizure medications can actually make their seizures worse. So there's just a subset of seizure medications that can be helpful with Dravet syndrome, whereas many of our commonly used anti-seizure medications can actually make things worse. So we have 3 innovations in this area that over the past few years have come to the fore. One of these is what I call pharmaceutical grade CBD. We are all aware of cannabidiol and its anti-seizure effects, but when we are dealing with a particularly severe form of epilepsy, we want to be able very accurately to dose cannabidiol or CBD. And in order to do that, we need a pharmaceutical grade, FDA approved form of cannabidiol so that I know dose to dose to dose, batch to batch to batch, that there is consistency in the dosing. I like this graph because it's a little busy, but I'm going to have you focus on the open boxes and the dark boxes. So the dark boxes are a high dose of medication, in this case, Epidiolex, and the open box is a placebo. And we'll see down here at the bottom that there were some individuals who they actually got worse when they were started on the medication. And this happens with every medication. It is something that we need to bear in mind, that just because a medication looks good on paper doesn't mean that for a given individual, it's going to be the medication for them. And this is why we never say never. We consistently try medications until we can find the medication with your name on it. So if we look at this less than or equal to 0, that means that these individuals either had no improvement or got worse, that a lot of placebo people were in that group. And in the moderate or high dose, there were people with Epidiolex who got worse. It is the nature of the beast. Let's then go all the way over to the right-hand side. And these are the super responders, the people who had a greater than 75% reduction all the way up to being seizure-free. And now we see a couple of placebo people did that, which is phenomenal. But you are much more likely to become seizure-free if you were on either a moderate dose or particularly a higher dose of Epidiolex. We commonly see this. This was also seen in the trials for Devries. Some patients did worse, but of the people who did better, it was the people on the higher dose, in this case, 20 milligram per kilogram per day of Epidiolex. Most common side effects, well, CBD is broken down by the liver, so it can inflame the liver a little bit. Those are the transaminases. When you get a blood draw and we check your AST and ALT, if those go up to more than 3 times what they should be, we need to take note and make appropriate adjustments. Generally, though, sleepiness, fatigue, these sorts of side effects were the most common side effects seen in the trials. And again, this is true of most anti-seizure medications. Another anti-seizure medication that is a niche drug, we call it an orphan drug, and it is FDA approved for the seizures associated with Dravet syndrome. Dravet syndrome, as I mentioned, is a very particular seizure disorder whereby some of our standard drugs will make it worse, but we have certain classes that make it better. And this is diacomet or stiripentol. Again, we see, if we look at the left-hand side of the page, that a few people on stiripentol did worse, but you were much likely to do worse if you didn't add anything. Basically, you added placebo. And if we look at the other end, we see that patients who were on stiripentol were much more likely to have a 75 to 100% reduction in seizures. The most common adverse effects are down toward the bottom of the page and include sleepiness once again. The last medication that I'm going to mention for chronic daily use is Fintepla. This was just recently FDA approved for, again, the treatment of seizures associated with Dravet syndrome. And it's an interesting medication. This is fenfluramine. Those of you, I'm old, I know it's subtle, but I've been around a while, and I remember the drug Fen-Phen. It was a medication for weight loss, and the first Fen of Fen-Phen, which was actually two drugs, was fenfluramine. So Fen-Phen was pulled from the market because patients who, a subset of patients who were taking it developed some significant cardiac issues, and it was appropriately pulled from the market. There were some studies, though, done in, I've forgotten which Nordic country it is, but in a Nordic country, of individuals who had one of these more severe forms of epilepsy, in this case, Dravet's, and they found that fenfluramine was well tolerated, that the patients did better, and that it didn't cause the cardiac valve problems. So there was a subsequent trial, and this drug has now hit the market. And again, if we focus in this case on the hatched box and on the solid box, we look at how many people did worse on this medication. Not many people who were taking the full dose of fenfluramine. Who became seizure-free or almost became seizure-free? It was the fenfluramine people. So again, we have a very innovative medication, and it has an innovative way of fighting seizures. It does so via a mechanism that very few medications have for the treatment of seizures, and that is it increases brain serotonin levels. Not surprisingly, for a drug that was half of the Fen-Phen drug in the past, one of the most common side effects was decreased appetite. Sometimes this is a desirable side effect, sometimes it is an undesirable side effect, but nevertheless, that was one of the most common, if in fact the most common adverse effect. And then we have somnolence once again. So all of our medications have the potential to cause somnolence. Enough about our innovations in the world of chronic daily treatment of epilepsy. With our plethora of anti-seizure medications, though, we know from a number of studies, a number of databases, that at best, 63% of folks who have epilepsy will become seizure-free with trials of various medications. Before I talk about more aggressive, if you will, options in that population, let me briefly digress, because the more severe your epilepsy, the more likely you are to have clusters of seizures, where you may go a period of time, then you have a cluster of events. And those are concerning for a multitude of reasons. They're concerning for safety reasons, risk of injury, risk of neuronal cell death. If you have too many seizures in a cluster, you can actually lose nerve cells. And you may go into what we call status epilepticus, which is one seizure after another, and becomes an almost self-perpetuating issue with seizures and will require hospitalization. So we would like to nip that in the bud, and we do this with rescue medications. It's generally accepted that if we take everyone who has epilepsy, about 5% of individuals will have clusters of seizures. But if we focus on individuals who are medically refractory, having ongoing seizures despite our best medical medication-related efforts to slow those seizures or stop those seizures, about 15% of those individuals may have clustered seizures. And for this reason, we have two new medications that have been FDA approved. Over the years, we didn't have that many treatments. We had diazepam rectal gel, which is quite effective, but many individuals were not accepting of having someone apply a rectally administered medication to them when they are in the midst of a cluster of seizures. Now we have two rescue drugs that can be administered via a nasal spray, so the ease of use, the rapidity with which we can intervene is far superior. When we look at how effective these medications are, we'll look over time. So this would be a 24-hour period of time. And the blue group are the individuals who got the study medication, in this case, Nasolam, which is intranasal midazolam, and then the people who got placebo are in the dotted group, and we see that those lines separate. So if you got intranasal midazolam, you are much less likely to have a seizure for the next 24 hours. Most common side effects, sleepiness. Sleepiness is consistently the most common side effect for any medication. Similarly, with the rectal diazepam, we see those lines nicely separate. So we know that rectal diazepam works. And now we have an intranasal form of diazepam, Valtoco, which has equivalence to the rectal diazepam. So we have options. Some of these rescue drugs are going to work better for some individual, the other one for other individuals. This is the beauty of innovations in this area, is we have options. What if, despite all of our efforts, we strike out in our goal of freedom from seizures? We know that happens in almost 1 of 3 patients. What do? Do we give up? Do we say, you know, life has dealt me a bad hand? And maybe it has, but we never give up. Or I would hope that we won't give up. So the first question is, I'm being treated for seizures. The assumption is that I have epilepsy, but maybe it isn't epilepsy. Maybe it is a mimicker of epilepsy. And there are many disorders that result in loss of consciousness that mimic epilepsy. And we are getting better and better at identifying those. There is, in the innovations front, I wasn't going to talk much about this, but there is a new technology where a camera can record the event someone is having. They put it through an algorithm. They can characterize that event, and they can say this is most consistent with a generalized epileptic seizure, a focal epileptic seizure. Syncope. Syncope is a fainting spell. It is loss of consciousness due to inadequate blood flow to the brain and has nothing to do with epilepsy, but it can look a lot like epilepsy. So we need to assure that we know what we're treating. And we also need to assure that we know which form of epilepsy someone may have. Let's take, for instance, our two broad categories, generalized. There are a number of individuals who have idiopathic generalized or genetic generalized epilepsy. Their brain structure is as normal as the day is long. They just have a subtle channelopathy, a subtle, almost, it's akin to a chemical imbalance, if we want to speak colloquially, whereby when the brain is in a certain state, it will hijack those networks and produce a seizure. But otherwise, this individual, you would have no idea that they have seizures. And we can contrast that with an individual who has focal epilepsy, who you may have no idea they have seizures unless that area takes off. So if we take a drug, say pregabalin, if I put someone who has focal epilepsy on pregabalin, there's a reasonable chance that they will have some improvement. They may or may not be seizure-free, but they will have some improvement. If they have idiopathic generalized epilepsy, they will get worse. Let's then take the flip side. Let's say ethosuximide. If you have absent seizures, idiopathic or genetic generalized epilepsy, ethosuximide is a great drug. It's one of our most effective medications in that regard. But if you have focal epilepsy, I might as well give you a glass of water. So we need to assure that you're on the right drug for the right form of epilepsy. And we're going to do this through an epilepsy monitoring unit. So this is why you want to, if your seizures are not adequately controlled, be evaluated by an epileptologist who may well obtain inpatient, so bring you into the hospital video EEG monitoring to accurately characterize your type of seizures. Why does this matter? Multiple reasons: seeking gainful employment, risk of injury, and we don't like to talk about this, but uncontrolled seizures, increased risk of sudden unexpected death in epilepsy. What do we do in refractory individuals? Well, one approach, and this approach can actually result in a cure, is to perform what I would characterize as destructive epilepsy surgery. So this would be to resect. Basically, one of our epilepsy neurosurgeons at the various epilepsy centers around the state can go in and physically remove the offending network that is producing the seizures, or they can do an ablative procedure where through a small hole in the skull, introduce a laser and remove that area of the brain. And if we are successful, then we can ideally get a cure. An individual may become seizure-free. Not all individuals do, but it affords the greatest opportunity for freedom from seizures. We have had innovations in that regard, but I'm not going to go into those today because those have been around now for a decade or more. What I will focus on is recent innovations in the world of neuromodulation, where, as you can see, we introduce judicious amounts of electrical current to discrete brain areas, and these have two effects on brain function. One is they have an acute disruptive effect on the seizures themselves, and the second is what we call a long-term neuromodulatory effect, that over time, these devices train the brain to fire in a fashion that is incompatible with seizures. Before I show you those, I just want to compare and contrast the ways that we evaluate these networks intracranially within the cranium. So these will be from electrodes, as we can see on the right, that are applied to the surface of the brain, or electrodes, as we see on the left, that are applied to that penetrate the brain and go to specific targets. And each of these has a role. Stereotactic EEG has come to the forefront at most centers because it allows us to target deep structures within the brain that previously it was much more difficult to target. In the end, the result of this monitoring, this evaluation, results in a recommendation that a person may either have a curative procedure or at least a more definitive procedure in the form of resection or ablation. But if seizures are arising from a part of the brain that, if it were removed, would result in a significant issue, weakness, speech difficulty, cognitive, just not functioning the way that we need to function, then we don't want to remove or ablate that part of the brain. And we're going to think along the lines of neuromodulation. This neuromodulation, this applying of current, judicious amounts of current to specific targets in the brain, can either be open loop or closed loop. Open loop means that the device is firing on a regular cycle, regardless of what is happening in the brain. With a closed loop stimulation, the device will be monitoring for a specific type of activity, and when it sees it, it will introduce current to the brain to disrupt that activity. So we have open loop firing, and we have closed loop that fires in response to some sort of detected change in brain. Our most recent innovations have been with two forms of neuromodulation. One is deep brain stimulation. This was FDA approved in 2018, but there continues to be innovation in this regard. As you can see in the upper panel, this involves the placement of an electrode into a deep part of the brain on each side, specifically a part of the brain called the thalamus, a little football-shaped group of neurons that interact with broad brain areas and therefore afford the ability to disrupt seizures from multiple brain areas. With the advent of what we call neuronavigational systems, where we can take very selective MRIs and merge them with this system, our neurosurgeons can hit very small targets. And this has been a boon to our existence when we target those deep structures of the brain, like the thalamus. What we do see with the deep brain stimulator, it was called the Sante trial, which stands for stimulation of the anterior nucleus of the thalamus in epilepsy. It's a very nice acronym. And we see that at the first year, we want seizures to go down. And so the seizures went down. In the second year, they went down a little bit more. And over the course of 7 years, we see a progressive improvement. This is that long-term neuromodulatory effect. This is what we see with DBS and RNS. The advances that are occurring are with regard to, in DBS, to what I would call directionality. So with an electrode, when you introduce current, it creates this sphere of influence, if you will, this sphere of current that excites everything within that sphere. We are now able to point that current in a given direction, which allows us to maximize the effect and minimize side effects. The last technology that I'm going to mention is RNS. RNS is FDA approved down to the age of 18 years. And this is a responsive form of stimulation. This is a little microcomputer about this big, wafer thin, embedded in the skull, so it's flush with the skull surface, and it continuously monitors the EEG, the brain activity. We then teach this device to recognize a seizure. Remember, early on, we noted that seizures are hardwired into the brain. They are a network that looks the same every time it starts. So we teach this device to recognize a seizure. When it detects this patient-specific seizure pattern, then it reverses the current and disrupts that seizure. And again, we have good data to say that the RNS not just disrupts the seizure, but over time, we see upwards of a 75% reduction in 75% of individuals. This is an example of a seizure that was recorded with an RNS device. At the beginning of this little epoch of EEG, we have that just baseline quasi-random appearance, but then something happens. See how thick that line gets? That is very fast gamma range activity. That network has taken off and it evolves. So here, where it turns blue, is where we are detecting it. And we're detecting it about a second into the seizure. But seizures spread quickly. I'm originally from Tennessee, and I like to do my little Tennesseeism that if we detect a seizure late, it's too late to do much about the seizure with that current. So basically, once the horses are out of the barn, we can stimulate the brain till the cows come home, and it ain't going to make a hill of beans difference. So we want to tighten that up. And here we have tightened up that detection. We're jumping in within milliseconds of onset, send that current, we disrupt the seizure. That is the goal with RNS. RNS generally consistently works well, but it doesn't always work well. So I'm going to briefly mention AI. So AI, artificial intelligence, big learning, machine learning, these are all terms that you hear when we think artificial intelligence. Ultimately, we are using computers. We teach the computer that, okay, this EEG is a seizure. This EEG is not a seizure. Here's another example. This EEG is a seizure. This is not a seizure in the same patient. And you do that for over 3,000 patients. This machine learning, it has all these levels. It analyzes, just like we analyze visually, auditory, what we feel, what we smell. We're integrating all of this in ways that we can understand. This machine is doing the same thing, but in ways that, frankly, we don't understand. But it comes to a conclusion, and it can learn how to recognize a seizure. So, what if we were able to group seizures by type and get the computer to do this, then maybe if I had an RNS device and I wasn't doing quite as well as I was hoping, but this person out in Colorado has a very similar profile on their seizure, then, but they're doing well. And so what this AI program can do is to find those people. And this person's doing well, this person isn't doing well. It turns out with all of these devices, there are over 1 million different combinations of ways that you can stimulate the brain in order to reduce seizures and ideally get rid of seizures. We can't try every one of those 1 million+ permutations. So the one in Colorado got some success with this, so maybe I can use it on me, and now I too can become seizure free. This is what we are looking to do. And in fact, we see this nice grouping here. It's color-coded. I love color-coded things. And there are a bunch of little dots here. Each of these dots is a seizure that has been characterized. And through this big machine learning, artificial intelligence approach, we can group similar types of seizures together and then go into the larger database and say who did well with which forms of stimulation and who didn't. So this is one of the ways that artificial intelligence is changing our view of seizures and allowing us to achieve significant improvement and potentially even freedom from seizures in someone who initially was not responding adequately. So what we are left with our current innovations is the following rubric. I have medically refractory seizures. Can they be localized? If not, then I'm going to perhaps get a VNS implanted, or a DBS, or a thalamic RNS. If, however, they can be localized, how many networks, how many foci do I have? If I have one focus, would it be safe to resect it? Would I be the same person walking out the door that walked in the door? If the answer to that is yes, is it eloquent cortex? You know, do I need it to speak, for instance? No. Okay, we're looking good. Am I willing to undergo an ablation? I have to be of the right mindset. If I am willing to undergo this, then I am a candidate for resection or ablation of that focus. If, however, it is not safe to resect, or if I resect it, I would not be the same person walking out the door that walked in the door, or I'm just, I like my brain. I don't want anyone to remove a part of it. Those are when we go with the RNS or DBS and potentially VNS systems. If we choose to do that, and I'm like, I'm much better, but I'd really like to go for that cure now. I've come around in my thinking. We can do combinations of therapies and we can revisit surgery. So just because we are going with current in our treatment, we are doing neuromodulation, doesn't mean that we might not benefit still from having surgery. And there's good data to see this. What is coming through the pipeline, we have some new rescue drugs that are being investigated. The pipeline doesn't mean that they're necessarily going to hit the market, because that pipeline starts to pinch down and you have to prove that a medication is going to work and be safe. Safety is paramount. In this pipeline, we have staccato alprazolam, over the years, Xanax. It turns out it hits the brain pretty quickly and may prove to be a very effective way of stopping clustered seizures. Transcranial direct current stimulation is now being investigated to activate areas of the brain to increase its ability, cognitive ability, but also to see if it can suppress seizures. There are always new medications in the pipeline, Crispimate, ganaxolone, which is a congener of progesterone, and other medications. We have cell-based therapies that can be individualized for an individual specific form of epilepsy and maybe the underlying cause at a cellular level, and various preventative therapies, not just anti-seizure, but anti-epileptogenic. So let's say if I have head trauma, I may, over the next 10 years, probably in the next couple of years, be at risk for seizures. If I could take a medication that prevented it, it would be great. Lastly, I will end with trending. With DBS to a degree, with DBS, but particularly with RNS, we are able to trend over time. For instance, long episodes. Long episodes in this setting are either seizures or times when an individual is very seizure prone. And this is a patient whom I know, and they were doing well going back in July and August, but they were having some mood issues. Mood issues frequently happen. So they were started on a medication for those mood issues. And lo and behold, as that medication kicked in, and it can take a month for mood-related antidepressants to kick in, there's an increase in brain excitability, and golly gee willikers, we have a seizure. That seizure occurred on the upswing of that brain excitability. We stopped the medication and they came back to baseline. My final parting thought is with regard to the broad view of epilepsy. So many of you are well aware, you observe this in your daily, weekly, monthly life, that seizures appear to cycle. And when they cycle, they vary in that cycle. They may vary, they may have a 10 to 15 day cycle. They may have a 20 to 35 day cycle. They may even have annual cycles where some people are more likely to seize in the spring than the winter and whatnot. And this is interesting information, but we have heretofore not been able to integrate that into our analyses, into our treatment. With trending devices like the RNS device, and there are other devices that are starting to be able to trend as well, we are gaining insight so that we can better interpret responses to medication. It turns out that everyone, or the vast majority of people, male or female, have a 20 to 35 day cycle. So it's not just in all individuals, just females, and just because of the menstrual cycle. It is more complex than that. And for that cycle, the brain has an increase in excitability and then it comes back down. And we call that a multi-day or a multidian rhythm, that 20 to 35 day cycle. Superimposed on that, we're going to have a diurnal variation. Some people have seizures more in the day, some more at night, some equally dispersed. And we're going to have an ultradian rhythm, which may be 10 days. So a lot of words here. Upshot of that is, if we look at the top graph here, these are all interplaying. And this line, when it goes up, the brain is more excitable. When it comes down, the brain is less excitable. And it all has to do with the diurnal day variation, the ultradian rhythm, and the multi-day or multidian variation. But regardless, what we do see is each of these dots on the upper plot here represent seizures. And there is a strong predilection for seizures to occur on the upswing of brain excitability. Not surprising, but it is so nice to be able to see this. So if I start a random medication, say someone has a seizure, I start a medication and they do well initially. I'm like, oh, the medication's working. This is great. But maybe I'm over-interpreting the situation, because let's say that you had a seizure at this dot. You saw me in clinic, maybe a month later, I'm like, we should probably start a medication. So we start to titrate it up. During the titration, my goodness, a seizure happened. We might conclude, oh, the medication doesn't work. But if we know that actually the seizure was going to happen anyway, we were on the upswing, we're not on the full dose of medication, to be able to trend this multidian rhythm is huge. So I thank you for your attention and enjoy the rest of this day. There's going to be an amazing amount of good information that you can put in your backpack and remember, and it's going to be helpful over the long haul, over the course of your epilepsy. Thank you.
Dr. Burdette, thank you so much. I know everyone is so grateful for all that you shared today, and you did that in such a beautifully hopeful way, fully accessible. And we just very briefly you've received a lot of questions, which is wonderful. People have been very engaged and excited about this presentation. And I do want to let all of you know, first of all, this will be recorded, or it is being recorded, and so it can be accessed later. And if we're not able to get to your questions today, we will reach back out to you. We're keeping track of those as well. I would like to just ask maybe a couple quick questions here before we move on to our next session. One is this: how difficult is it to administer a nasal administered treatment when the patient is having an active seizure? And if the patient is having several seizures throughout the day, would you use midazolam and midazolam in between seizures or as a rescue?
So with regard to the first, how tough is it to administer? And nothing is going to be easy during a seizure. But if you're experienced, as many of you are, in seeing seizures, it will be more straightforward. All of us remember the first seizure we saw, and it's like, oh my goodness, what am I going to do? But over time, we become experienced and we realize that although it is a difficult situation, a stressful situation, that it is going to end. So when someone is having a seizure during the clonic phase of the seizure, it may be hard to find the nostril. But oftentimes with seizures, there's a lot of increased tone. So it is surprisingly straightforward. These are in a pre-filled syringe, not a syringe, a little applicator, I'm sorry. And you take them out, you get it, you put it up there. You don't have to prime it, and boom, one squirt in one nostril, if necessary, a squirt in the other nostril. Very straightforward. And unless there's a lot of movement, you may have to wait till they slow down because you don't want to miss. But there's nothing, they don't have to inhale during this. This squirts it up, and in the nasal mucosa, it is rapidly absorbed. With the second, can you briefly say that one again?
Yeah, I think it was asking about would you need to do it multiple times throughout the day?
Yes. So what is the timing for this? And we know actually from the nasolam trial that 70% of seizures self-terminate. So if you are in that 70% of individuals who have clusters, the initial seizure will end, knock on wood, in which case you would administer it upon cessation of the seizure activity. If, however, it is one of those unusual situations where the seizure activity continues, then the second it is evident that the wheels are falling off of this situation, you want to administer it. Even though these are rescue drugs, we tend to focus on seizure clusters, but there are three groups of people that I find use rescue drugs for, on a regular basis. One is obviously people who go a period of time, boom, 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 tend to cluster. Okay, we can give it during the cluster here. There are other individuals who may live out away from EMS services. So you need to have a rescue drug available. And in those individuals, if they convulse, oftentimes I will ask their caregivers to give them a drug to prevent a seizure emergency. And lastly, there are those of us who are concerned that, oh my goodness, what if the wheels were to fall off? So I like for them to have a rescue drug available just in case.
That is so helpful. Thank you so much for your time today, all the great work you're doing, and all the ways you've invited us into thinking about innovation. So thank you very much. And you all in the chat, if you want to just say a word of gratitude to Dr. Burdette, we thank you. And I hope you have a great rest of your day. Thanks for being with us.
Thank you for having me. I look forward to the rest of the conference.
Absolutely. Thank you.
Thanks.
And friends, we are going to begin our second session of the day. And this is such an important one. Our next session is entitled Unpacking the Trauma of Epilepsy. And I'm really looking forward to introducing our panelists. And I want to begin by thanking them. You're going to meet them in just a moment. I thank them for being present to this really crucial topic in the life of our community. And I hope that everyone here today will learn some new innovative tools that will help you in processing trauma and caring for trauma as it emerges in our bodies. So I'm pleased to share we have an excellent panel of speakers with us today, and I would like to welcome Dr. Hussam Shaker, neurologist at Mercy Health, Amber Deering, a licensed professional counselor and art therapist at Mercy Health, Erika Oliver, a parent of a teenager with epilepsy, and Laine Richards, a young adult with epilepsy. We absolutely believe this is a vital conversation for our community, and we welcome you to this time of learning. Welcome. And as we begin, for everyone here also, I want to recognize and honor that this can be a difficult topic because it can bring up memories, emotions, sensations physically. And so I just want to encourage everyone tuning in to hold this space, and most of all, to hold yourselves gently. If you need to take breaks, it's okay to do that. And please know that we will be discussing how people can get help, treatment, and community care around all of these kinds of experiences. So to begin with our panelists, I'd love to invite each of you to introduce yourself briefly, and would you tell us what makes this topic so important to you personally? I'd like to begin with Dr. Shaker.
Morning, everyone. It's always a pleasure to join you, and I was happy also to see Dr. Burdette. It's always nice to see him and listen to his lectures. So I'm Hussam Shaker. I'm an epilepsy doctor. I'm more specialized in surgical epilepsy. I'm leading the surgical epilepsy program in Mercy Health, St. Mary. I had my training in Cleveland Clinic for epilepsy and surgical epilepsy, and I recently moved here 1.5 years. I was here also 4 years before in my training in Spectrum and Mercy Health. The topic is very unique, and it's not an easy topic for physicians. It's important for me because I see it on daily basis. Almost in every single patient, this topic will come in my note and in my conversation, and every patient is different. So I don't have one solution, one answer for every patient, so I can give it. So that's why it's challenging every time you have to come up with something that tailored to this patient based on what type of stress he or she they have. Yeah.
That need to have that care approach with each patient. It's wonderful. And Amber, how about you? If you'd introduce yourself and what makes this topic important to you personally?
Sure. Yeah, I first, about 6 years ago, was invited to lead an art therapy group through the Epilepsy Foundation. So I'd like to say that's kind of when my journey began with the epilepsy community. And basically what we found after a couple 6-week groups was that the art therapy was very beneficial and there was quite a demand for those services. And so from there, partnered with Mercy Health, we shifted to doing a monthly support group that was art therapy based. And so I've been doing that for over 6 years now, and really enjoying the relationships that I've built within the community. I've really had the opportunity to really get to know the participants over that vast amount of time, which I think is different than other therapeutic settings sometimes. So I've really become very inspired by what I've learned from them personally and professionally. So
thank you, that's lovely. And Erika, how about you? Welcome. We need to unmute you.
Good morning. I'm happy to be here. Thanks for inviting me. My daughter is 15 years old and she was diagnosed in 2017. So can't believe it's almost 5 years ago now. She was 11, I believe, when she was diagnosed. We were unaware prior to her first grand mal seizure that she had epilepsy. She had a number of other issues going on, and we just weren't educated enough to see that she was experiencing absence seizures all the time. And so after her first grand mal seizure, in my car on the highway in the middle of a blizzard, that's where our journey began. And it's been quite a roller coaster of good and bad since then. I'm happy to say that at this point she's quite stable on with her seizures. She's on great medications, and she was only found to have one at her last EEG. She also experiences, in addition to myoclonic and absent seizures, she also has psychogenic seizures, and that seems to be our larger battle at this point.
Thank you for sharing that. Yeah. And Laine, welcome to you. If you'd introduce yourself.
Thank you so much for having me. I'm Laine. I'm a sophomore at Grand Valley State University, majoring in special education. I do have drug-resistant juvenile absence and myoclonic epilepsies, along with tonic-clonic seizures. Discussing the trauma of epilepsy is really important to me personally because I'm a big part of it, and trauma truly impacts every part of our lives. It's super important to talk about this, and thank you.
It is, and thank you. Thank all of you. I really appreciate that. I'm wondering, from your experience, from your life, from your practice, how would you define traumatic stress and post-traumatic stress in the sense of what happens in the brain and the body? And how can this show up in an experience of epilepsy, both in people who live with epilepsy and also their caregiving family members and friends? Amber, would you mind starting with this one?
Sure. Yeah. So traumatic stress, I think there's a lot of sometimes misconceptions around it because it's really a common normal response to experiencing or even witnessing a traumatic event. So that goes for the person that's actually experiencing the seizure or a family member or caregiver that's witnessing the seizure. It's, traumatic stress versus post-traumatic stress usually isn't quite as long lasting, has some of the similar symptoms, and obviously can be scary and debilitating and anxiety provoking because of the changes that happen in the body and brain based on that trauma. But if, it resolves within a month, that's completely normal. So when it is more intense or starts to affect more areas of your life, that's when we start to get into the more post-traumatic stress, which I know is probably the next question. But did you want me to speak to that piece as well, or?
Sure, if you'd like.
Okay, so basically to protect ourselves from harm, our body and brain makes really second changes to try to protect us from future harm. So what it does is really start to pay attention to stimuli within the environment that's associated with our seizures, which might be like sights, sounds, those kind of things, smells, all of those things. And what our body does to protect us is go into what you're probably familiar with is fight or flight mode. And our bodies are really hardwired in this way to protect us and to keep us safe. So it's actually your body trying to help you, not harm you. Again, it's a very normal response. And some of those symptoms might be, your heart pumping really quickly, muscles tensing, sometimes digestion stops because your body's really focusing on fight or flight to get away and protect ourselves. So again, a lot of those symptoms can be very distressing. And if they last for more than a month, I would say, after a seizure, and again, are starting to really affect your ability to function in everyday life, that's when you should seek out medical support from a medical professional to really learn some coping skills and help to manage that fight or flight response.
It's really helpful, and I think probably something so many people on this Zoom call can relate to very much. Dr. Shocker, anything you'd like to add with this?
Yes. So from brain standpoint, our brain is very complex organ compared to any other organ in our body. We have about, now they are talking about numbers of neurons, about 85 billion neurons and 85 billion non-neuronal cells that they support our neurons. And I think in 2006, they found that every neuron has about 10,000 to 20,000 connection with other neurons. So can you imagine this complexity in our brain? Sometimes we try to simplify it, but honestly, it's very complex. So our brain trying to execute a lot of functions simultaneously, a lot of networks working together. The brain needs the energy. When we are in the danger mode, a lot of energy, a lot of focus goes to the fear network. Like I'm talking about the stress in epilepsy and the stress in general. So in that, all the energy goes to the like amygdala region, that it's the like the structure that govern our survival instinct. So that reflects on all other modes. So it affects our memory. That's why you see it very commonly in people with epilepsy. I don't remember in general, like patient with refractory or difficult intractable epilepsy, when you ask them about their memory, the vast majority, they will give you, yes, I'm struggling with my memory. Because when you have some network very activated, other network, they don't have the enough energy to save a new memory, especially in around amygdala, hippocampus, anterior cingulate. That network, we know very sure now, it's the autonomic, responsible for increased heart rate, increased respiratory, the fear in the face. You look to the patient, you see the fearful expression in their face. So that reflects on all other networks in the brain. And when we talk about the stress, people, they might think stress is like one thing. No, stress reflects on everything. It reflects on your mood. It reflects on your sleep. It reflects on your daily activities, on your mood, and your memory, as I mentioned, and a different type of memory. That's on the structural level. We all know also a lot of hormonal changes in the brain, a lot of changes in like neurotransmitters, and it also affects like not only the central nervous system, it also affects, there's a new studies now, about it increase the risk of inflammation. So increase the inflammatory status in the body, which reflects on your heart, on your lung, on your kidney. So honestly, I feel most people, they still underestimate the impact of stress in our patient. Unfortunately, we always focus on the medical, the medication, the pill that I'm gonna give the patient in this 20 minutes visit, and that's it. It's like a magic pill to address all the concerns of our patient. So yes, a lot of changes occur in the setting of stress in the brain and in other organs.
I so appreciate that. I mean, first of all, you walking through what is going on and those changes in the brain, but also the reminder that we sometimes need a medical approach, and we also need relationships. We also need a variety of ways of caring for that stress, ways of doing that with our bodies, with the ways we use time, with the ways that we ponder kind of our larger meaning in life. All of that is so important because, as you said, this is physically impacting the whole person, and our whole lives are impacting our bodies too. So that is so, so important. And Amber, I really appreciated you naming what I hear so frequently from our community members, which is that people do go into this fight or flight mode when there's sometimes a trigger around traumatic memory in connection to epilepsy. Maybe, as you said, there's a sound or movement that's similar to the start of a seizure, or people just find themselves feeling generally hypervigilant. And then, of course, traumatic memory can work differently than other types of memory. So sometimes people are getting these sudden, intrusive memories of past seizures or past difficulty. And so, though that can get better with time, and of course, we always want that to be the case, it doesn't always fade entirely from the background. And I'm just wondering, especially for Laine and Erika, if you might speak to those kinds of experiences, and if you have any good advice or helps for people. What's been difficult in that, and what's been helpful for you in that. Erika, could we begin with you?
Sure. I have a lot of times, I think, where I just kind of flood back to being with my daughter alone in a scary situation, something that I didn't understand and didn't know what was going on. And obviously now that we're years into this, I feel a little bit better because I'm educated, so I know what to do, and I would know what was happening should that happen again in a situation like that where I was kind of stranded. I'm very careful where I go with Annie and who I go with, because I don't want to end up in a place with her that's rather remote where I'm by myself. And I've learned through trial and error what those places are, things that she wouldn't suspect, but in a place where I wouldn't be able to get her help quickly. So those are, along with a number of other smaller things that go along with it. Those are big parts. Annie, she doesn't remember anything, of course, about the only grand mal she's had. She's more aware of her current situation of like some of her absent seizures and being in class and, not knowing where she's at, and kind of coming to in that sense, it seems to be a very stressful environment for her, the school situation, because she can get lost so quickly with like where they are in class and that type of thing. But she said to me something the other night. She and I were driving, and it was at night, and it was just the two of us, and we were coming back from a friend's house in Helen. And she said, "Mom, I don't like being on the highway with you because it seems to lead to bad things." And that was the only bad thing that I can remember happening on the highway with just her and I. And so I asked her about it, and she said, "Yeah, the lights are bothering me, and it just makes me like I get worried, So I think for Annie, the experience is very different than mine. Mine, of course, is in being able to protect her and help her if she needs it. And hers is a little bit more just trying to stay on her square and not lose track of what's going on. We both have our own mental health professionals to help us through some of those things, because it is very difficult. And Annie was out of school for a number of years. And I think for her, she would tell you that's her biggest trauma.
Yeah. And I'm so glad that you all have sought out those professional therapeutic people who can walk alongside you and accompany you through that. And I would say to anybody watching, therapy can be so, so helpful. And there are some ways too that we can maybe give you some advice on how to find a therapist. If that's something that you've never done before, or something that you think you might need again, you can always contact us and we'll try to help you learn how to find someone. Laine, I'm wondering how you might speak to these things.
I am so sorry. It's kind of funny. I actually had a tiny absence seizure while you were asking the question. Could you repeat that?
Yeah, absolutely. I'm so glad you asked for me to repeat that.
Sorry.
No, there's never need to apologize. That's what we're here for, is to help each other with these things. So we know that when people experience seizures and the outcomes of that, and our family members as well, though, that sometimes we might have experiences where we see something that was a trigger before, or we experience just a sense of being generally hypervigilant because we're dealing with uncertainty, right? And I'm wondering if you experience some of those things, and if you do, what helps you, and if you have any advice for anyone else.
Okay, thank you so much. I really appreciate it.
Oh, of course, yeah.
So one way that this has truly affected me, and how I have to be hypervigilant and basically pay extra attention all the time. I actually used to be on the swim team when I was first diagnosed, and for a couple of years after. And I'm sure, as many of you know who are listening, swimming and epilepsy, typically they're not buddies. So I had to leave the swim team, and that was really, really difficult for me. That's the first thing that comes to mind. However, I did start seeing a wonderful therapist who I love, and that has really, really helped. And always talking to friends, they are definitely able to help me make light of it all. For example, the little joke I made about swimming 2 years ago, never. I've learned to laugh at it.
Yeah. Well, I think having that larger picture can be so helpful, and having some friends who can both hold the seriousness of what we need to talk about, but also can even be a little playful and just helpful. Like, we all need things from each other too. Those little moments of access of like, will you repeat that again? Or could you help me with this thing I need in my own stress? We all have those needs. And I appreciate you naming that. I think one of the things that's really unique about epilepsy specifically, and would also be applied to PNES and psychogenic non-epileptic seizures, is just how chronic this kind of larger traumatic stress can be, and post-traumatic stress can be. And so I'm wondering, for our clinicians, if you could tell us a little bit about the unique things you see in people, because they're dealing with this in a chronic way. For instance, there is the diagnosis of PTSD, post-traumatic stress disorder. Some people also talk about CPTSD, with C standing for complex, meaning that the traumatic events are more chronic and long-lasting. So how do you see this showing up in your practice, and what approach might you have? Dr. Shaker, would you speak to that, please?
Sure. As you mentioned, it's all about uncertainty, the stress of uncertainty, and stress of, if it's not about uncertainty, people, they are stressed about what is the long outcome and unpredictability of the future. These two things, I think, increase the level of stress in epilepsy patient. And I always think about it, that the stress of having a seizure maybe is worse than the seizure itself. The stress that people, they live with on daily basis, on hourly basis. So we have to address that, because it's sometimes more dangerous than the seizure itself, because we keep thinking about it. So you mentioned about the two different, like PTSD and CPTSD. I think once the patient with epilepsy goes to the refractory, or to more than 2 to 3 years, we start to see what you call the CPTSD, which the difference, it's hard to see like one line difference between the regular PTSD, because it's all at the end, post-traumatic stress. The long exposure and the long-lasting exposure to the stress for a long time definitely reflect badly on our brain. It's also I think it came from that people, they cannot hold or prevent themselves from going to the extreme and being emotional. That's why they added the letter C, because it's different from PTSD that some people, they have it, they're still able to function. But with epilepsy, or when you go to CPTSD, you cannot hold your emotions. So it will become very difficult for you. It also reflects on the personality that people, they become more avoidant. They try to avoid being engaged in social activity, in the community, in the friendship. They become not comfortable bringing anything related to this topic. So that's what we see it. When I see this category, the CPTSD, and if we go back, what the reason for that, honestly, and from personal experience, the early that the trauma started, the more it affected the patient. The early age it goes back, the most significant the PTSD is. And if we talk to other criteria that I see, the long exposure to the stress, regardless what kind of stress, everyone has his own individual high-level stress. So that's what I see on daily basis, how I see the CPTSD in the epilepsy patients.
Yeah, thank you for that. Yeah, and for those who may be curious, like that sort of sub-diagnosis of CPTSD has been talked about for a long time, realizing that if people had trauma earlier in their life and it was much more long-lasting, it was presenting itself in some unique ways. And I think that can be applied, of course, to dealing with this chronic kind of uncertainty that people with epilepsy and their families and friends experience. Yeah, Amber, I'm wondering if you might like to speak to this too.
Sure, absolutely. So, yeah, with complex PTSD, like Dr. Shaker mentioned, it's usually related to like more of a longer period of time where trauma has been experienced. So with, straight PTSD, so to speak, which can also be chronic, or acute, or those kind of things. But with PTSD, usually it's with treatment able to be resolved, I would say within a few months to a couple years. With complex PTSD, it's usually because there's been like a multitude of exposures. There's been repeated seizures, for example, or maybe there's been some secondary trauma related to the seizures that makes it more complex by definition. So like maybe someone got into a car accident because they were driving when they had the seizure, or they fell and had secondary injuries, or maybe they experienced abandonment or neglect by family members or support people, that again, makes it more not just about the seizure, but more complex. And then inherently it does affect more aspects of the person as a whole. Like Dr. Shaker mentioned, a lot of interpersonal struggles with the complex PTSD. So, or behavioral. Sometimes our PTSD triggers are not as easily identifiable, maybe as they might be with just straight PTSD. It might show up as just more irritability or defensiveness, or being a little bit more argumentative or on edge when we experience those triggers, which could be, as simple as a smell or a taste that associates us with that trauma. And so again, it makes it just inherently more complex to kind of manage at times, but still very treatable if you're, seeking out professional help. So.
Yeah. And speaking of that, would you mind telling us maybe some of the professional approaches or or how some things that people might pursue if they need some help with it?
Sure. I think it kind of varies depending on the severity of the trauma and what's going on. Some people respond to different treatments better than others. I think that art therapy, for example, which I'm trained in, is very helpful in that it does create a bilateral stimulation in the brain, especially when we involve both our right and left hand, and we're crossing that midline in our body. It's, the page or canvas is something that's like containing in a way, in the sense that it's really kind of a safe place to put our emotions and those difficult thoughts and feelings related to our experience of trauma. So it becomes containing in that way, while also helping our brain to what's called process our trauma. So what we want to do in order to like decrease the severity of our physiological response to trauma triggers is to try to reprocess them, which means store them in a different part of the brain that's associated with calm and safety versus fear and anxiety. So the amygdala is kind of there to help us, but kind of the culprit of like just those instinctual responses that make us respond in a fight or flight mode. But when we reprocess those triggers, work on grounding techniques and ways of, maybe it's mindfulness skills, different ways of like conjuring up like feelings of calm and safety when we're either talking about our story or experiencing those trauma triggers, we can store that information in a different part of our brain, which then over time, even when we experience our triggers or the stimuli associated with them, our response changes, and it's not as severe and as debilitating. So besides art therapy, there's brain spotting. There's a lot of growing information that shows that that's really helpful for really severe cases. I think EMDR is a beautiful way to work through those triggers. Other than that, cognitive therapy can help with some of the thoughts and how they're so tied in with emotions and beliefs when trauma is complex. So there's really a lot of different avenues that you can explore treatment-wise to get some relief, whether it's just some mild stress management to, really severe or debilitating trauma triggers.
And I just so appreciate that, because if there are so many approaches, that means that there are many things to try. It's like what Dr. Shaker was saying, of you have to approach the care to the person and the whole person uniquely. And I really love that. And thank you for mentioning those things. Obviously, stress is a big trigger for seizures themselves. So, you might have seizures and then be experiencing trauma, and then that stress could also kind of fold in on itself and create more seizures too. And so I'm just thinking about that, the frequency, the severity of seizures. And I'm wondering, this to Laine and Erika in particular, how would you encourage people to care for their stress generally in order to also impact their epilepsy in its severity, its frequency? Laine, would you speak to that?
Yeah, of course. So as you said, it's a vicious cycle. Stress leads to seizures, seizures lead to stress, and on and on. So it was really tricky to find ways to cope with that at times. But again, I did get a wonderful therapist, and she has helped me through so much over the years. And like I said earlier, I always joke about it. Some of the jokes I make are a little questionable, but in a good way. So that's really how I cope the best I can. I talk about it. You can't tell I'm a bit of a talker sometimes, but I talk about it with my family and friends, and it helps a lot. Sometimes just getting it out, even if it's tricky, is the way to go, because in the end, like I said, it helps.
Yeah, thank you. I mean, as you said, like talking it out and working it with a therapist, and also doing that with the people who are in relationship in our lives. I think I hear regularly, by the way, I grew up this way too, like people saying like, okay, I kept my epilepsy a secret for a long time. You know, like I felt like I couldn't say things, or I held back, or I felt a sense of shame around that. That all gets internalized. So finding the best people, the safest people to kind of process that is important. Erika, anything you would add? How did you reduce your stress? How does Ani do that? What's helpful?
I think Ani would agree with Laine that therapy has been very helpful for her, and that's an extremely safe place where she works on all different kinds of skills. Ani has done all kinds of things in terms of that. She does a lot of drawing and coloring and all that herself. She does some journaling. She doesn't talk so much to friends about it at this point, but she does talk with family, trusted family quite a bit. She's been part of the group that the Epilepsy Foundation offers, and I know she likes that. She's recently found a friend at school who has epilepsy as well, and that has been remarkably helpful for her. That's been an incredible thing for Ani to have that familiarity. And she's like, Mom, I feel like when I'm talking to her, it's like a mirror. Like, so she finds a great amount of help, I think, especially for her age, and that a peer who understands her. For myself, I do a whole lot of different things, but by far, the parent support group is the best thing that has happened for me in the process of managing my stress of being a parent of somebody with epilepsy. So I call them my mom's group, and we have a really safe, great group of women who we all have different things going on with our children in terms of the variation of different levels of severity. But for sure, that's been a place of a great amount of support and education. And I think for me, the community is the most helpful thing for sure. My Tuesday nights are the most important in terms of how I manage having a child with epilepsy.
That's so sweet. Yeah, that commonality of realizing you're not alone, because I think that a lot of people living with epilepsy and also their families can feel that sense of isolation, or that they're the only ones they know. And that's one of my favorite things we get to do. The Epilepsy Foundation is just introduce people to each other, because that's just a total game changer. And we do have 5 call and connect groups. I can see they're talking about that in the chat as well. One for adults with epilepsy, one for older adults with epilepsy, one for young adults with epilepsy, teens with epilepsy, and parents of people with epilepsy. And it's just so beautiful. Dr. Shocker, I was wondering if, what sort of things do you encourage people to do to ease their stress overall?
Yes, that's a good question. If you allow me, I will touch briefly on the PNES because I did not comment.
Oh, yeah, sure.
Yeah, because it's very important. The data showed like almost 1/3 of our patient to epilepsy monitoring unit, they have non-epileptic events. So that's like a huge population of people that they are labeled with seizure because it's PNES. So it's still seizures. And we see it day after day that the co-occurrence of epileptic and non-epileptic. So we have, as a physician, we should be very clear and convey message to other primary physicians, other subspecialties that, okay, if you see PNES, does not mean much if you are thinking about the old schools that, okay, stress related, that mean, oh, nothing, just go and no medication for that. No, that's very important to recognize this group of patients. And we still need a lot to learn what the exact etiology and mechanism behind the PNES, because it's completely different from faking, malingering. I always have this conversation with the patient. I always tell them, so far we know that it's accumulation of the stress in the subconscious area, that it gets released in every patient differently. Some patients they cannot see, some patients they cannot walk, some patients they have seizures. They might have any neurological deficit with the amount of stress. And they, most of the time they say, but it happened to me, I was happy, I was in the wedding, I said, yes. I say, yes, because you are trying to suppress them bad emotion at this moment. You try to suppress what you want to live the moment of happiness. You don't want the unpleasant feeling at this moment. That you become very fragile. And now with the technique of stereotactic EEG, sometimes we see some networks getting activated during the PNES, because I think it's very deep area in the brain that we cannot see on the scalp EEG. We cannot understand the mechanism so far. To answer your question, first of all, I always try, it's not the visit just to see the patient and tell them this medication. I always review all their medications. Sometimes patient taking other medication that worsen their stress, that works on some receptor in the brain, that makes their stress worse. So I always review all medication. And as you know, most of patients with epilepsy, they have migraine, ADHD, they don't know the etiology, but they have tiredness, fatigue. They don't know why. And this is like the co-occurrence of these 4 or 5 symptoms. They always come together, and we see it in almost all patients. So we have to address medications first, establish the right diagnosis, review all medication. Like example, if patient, they have a lot of depression, anxiety, I avoid some medication that worsening, like Keppra, for example. It's amazing medication, but I tell my patient, if you see, and honestly, I tell their family, when I see the patient, I always ask, I need collateral information. I need family. I need someone who lives with you. I need someone who you spend most of your time with, because once I hear someone lives alone, I feel anxious. I always call, can you find a way to have someone live with you? Because whatever you tell me, maybe you are unaware of what's going on. You don't know what's happening when you are asleep. You don't know when you are watching TV. Are you staring? When you tell me you don't have seizure, but you tell me a lot of things getting worse, I have to question that, because I need someone who can live with you. So I always try to find solution for that. I need a supportive family or supportive friend or whatever. Just I need some support, social support for the patient. That's critical in epileptic and non-epileptic. I always tell my non-epileptic patient, listen, if you need to get rid of your non-epileptic, you need 3 things. Number 1, you have to admit that I have them. Number 2, you need supportive family. Number 3, you need to do cognitive behavioral therapy. And if you do all of these, the study showed about more than 80% chance you will get rid of these and you will be with no seizure. The other thing, you need to get the confidence back to the patient. How that happened? With seizure freedom. So we still, every day we knew more about epilepsy. Every couple of days, couple of weeks, we have a new medication. I think this is helpful for every patient to know that if you have, especially focal epilepsy, not responding to medication, we have a lot of other non-medical surgical. We see the data from doing stereotactic EEG, finding what the network, do laser ablation, do RNS, or do even, I have 3 patients last year, they had seizure twice a week, grand mal seizure. We found 2 centimeter area that this is the epileptogenic zone. We lasered it or we removed it. Patient now seizure free for 7 months, 8 months, they get their job back. So trying to achieve seizure freedom in focal refractory epilepsy, we should never forget about that. And we should increase the awareness in our society, in our primary care physician, in our general neurologist that, listen, a lot of advancement in epilepsy. It's not about 4 years ago with the RNS data that Dr. Burdette presented. Every day we understand the epilepsy better. Some RNS data showed that the patient have seizures only like in the morning. There's published paper, Dr. Alexopoulos, about it, that patient was taking caffeine too much every day and this moment. So he asked the patient, why are you having seizure at this moment every day? He said, oh, I take another Nespresso and shut the espresso. He said, can you please don't do that? And no more seizure at that moment. So we can work on what we have now data to adjust our medical treatment, surgical treatment. And from my standpoint, I always try to engage supportive family or supportive community to the patient. I said, okay, where's your wife? He said, oh, it's at work. Can I call her? I always put them on the speaker, the spouses. I always say, do you have kids? Let me call your kid. Let's put them on speaker. I need some collateral information, and vice versa. When their family, they know about them, that they are really sick, they are really need support. Last week, I had a patient. I called her sister. I told her what happened. And she told me, you know what? I will bring her. She will live with me. She came to the hospital next day. And she told me, I will take care of my sister until she's seizure free. and her sister was crying. It was like emotional moment. So you try to engage the family. I think it's critical in epilepsy. It's not one solution. You need to work on multiple domains, community, society, increase awareness, even in the family, the close family networks. You need to tell them about, the patient feels like very satisfied when you tell their family that they need more care. They need to be more vigilant.
I love that approach. And first of all, I think that's so effective and so meaningful. And it also reminds me, you see the people on the screen right now, and then of course, all the people we're connected to. I think it's a good representation of how we as a team and we as a whole epilepsy community can be participating in reducing each other's stress and our own. I mean, we've got epileptologists here today who are trying to get us to seizure freedom. We've got therapists here today who treat in those approaches and so meaningfully. We've talked about the role of family. We've talked about the role of friends. Laine, you mentioned your friends. And of course, the Epilepsy Foundation of Michigan. We are trying to connect people to each other and change what those outcomes are. And then you as people with epilepsy, when you are those mirrors to each other and we take care of each other, we've got people in our groups who call each other outside of the time of the group and just check in with each other. It has changed so many lives. So we're all doing that together, and it's really, really beautiful. I'm just going to ask one more question, and then we're going to open it up to Q&A. I know we've already received some. You can put your questions in the chat box. As they're doing that, I'm just wondering if each one of you would briefly share what sort of encouragement would you give to individuals and families who are experiencing trauma and seizures? Just, we've talked about a lot of approaches, but what's your encouragement if you want to give a little, pep talk? Laine, I'm wondering if you want to give a pep talk.
I've been looking forward to this. So going back to coping, that's always where we end up. You need to find ways to be better. So I mentioned that my main coping mechanism is humor, and that you should always find a great therapist who will help you. They really do help. It's uncomfortable at first telling someone everything. It feels unnatural, but it really is helpful. And then lean on your friends and family. They'll annoy the heck out of you. It's true, but they want to have your back and help you. And then remember that you're part of a community. You're not an outsider. You're not alone. There is an entire community for you that is right here on the Zoom, actually. And I know me, and I'm sure the rest of the panelists are always here. And then one more thing that I really like to live by, it's a quote by C.S. Lewis. It's, there are better things ahead than any we leave behind. I've realized something that always helps me is look to the future. Sure, some stuff that has happened in the past regarding your epilepsy or things that have been whiplash from your epilepsy have been really, really, really hard. I know better than most, but if you keep looking ahead, things do eventually get better. There are going to be ups and downs, but always look ahead. That's my pep talk, I guess. That
was a pep talk. That was great. Erika, how about you? A little encouragement for people.
I think by far there's Dr. Shacker was talking about the PNES and that piece. And for me, doctor educating me about the difference between that and the other seizures Ani was having was really helpful. And our medical care in terms of our team of medical professionals has changed, and we've been experiencing a major benefit from just a second eye approach. So for me, the education has been a really important piece. And I think for Ani as well, I think that she feels very confident at this point, and understanding the difference in those two things for us has been life-changing. And I think the other piece is that finding that community and connecting is really important. And that's of course available to everybody, at least as a parent. I know that's been a great group, really supportive and very welcoming. And I guess the last part of that is that, I have some friends who have children with special needs as well. And one of them said to me, Erika, eventually this will be a new normal for you. And it's taken a long time, but I kind of feel like we're at that point now where this is kind of part of our daily life, and we cope with it and we manage it. And some of the ways that we work as a family has changed, and some of the ways that we work with Ani has changed. But it's a journey, and it's finding what works. And sometimes it takes a while. I mean, when Amber was talking before about, a month or a couple of years, I thought, man, we've been doing this for 5 years. And I feel like recently we have the right things in place from a number of areas that really contributes to getting us into a place where this is part of our rhythm. And sometimes it sucks. I mean, sometimes the rhythm of it sucks. But we learn every day more things that are helpful, and we have a real wide approach to that. And I think it's finding, to the other parents out there, and also other people involved, it's just finding the right mix of things for you, and it will eventually happen. It's just it's a process, and sometimes it takes a while.
Yeah, thank you. Amber, any encouragement you'd like to offer?
Yes, absolutely. So, yeah, I mean, I guess the biggest piece is just to reiterate how important it is to reach out for help, because and reduce that stigma yourself, and get the help, because there are so many treatment options out there to help with your stress. Whether it's talk therapy, like Laine talked about, it's, can be very healing just to tell your story. That's part of actually, reprocessing our memory, or is to share it with someone who's safe, that we trust, whether it's a therapist or family and friends. So really utilizing our support system is very important. I know that's one thing that I've learned from the community that I've worked with, is just how much they blossom within the support of a support group. You know what I mean? Developing those relationships, those friendships, sometimes outside of their family and friends, so important. And I guess that, the other piece is just that, to remember that PTSD isn't a mental illness in most, situations. It's a condition, and it's something that can be treated, and yes, it can be very debilitating, but it's not a mental illness. So, debunking that stigma and learning to friend our anxiety in a way is what I tell my clients. They usually don't like it when I say that, but they thank me later, because, when we push against our anxiety, or, our stress response escalates, when we start to notice those signs and symptoms of just anxiety or hypervigilance, we can really snowball that stress response, like we were talking about. So learning to kind of normalize some of the physiological responses in our body, and embrace them in a way, which can be difficult, can definitely help to manage everything. And yeah, we're all here to support you. And
Great.
Yeah,
that's really fantastic. And Dr. Shaker, I'm going to let you give your encouragement too, but I'm also going to ask you a question. Yeah, someone was saying, from my understanding, stress can be a trigger for a seizure. So how does stress regarding having seizures affect the likelihood of further seizures?
Yes, it's a great question, and it's like the chicken and eggs, which one leading to the other one. When I admit the patient, I try to understand epilepsy for every patient. Then when they come to me, they always, which medication can I try? I said, let me understand your epilepsy first. Let me establish the right diagnosis. What kind of epilepsy do you have? So I try to record at least one seizure. The first thing I say, what kind of stress you have, and how you can bring your seizure, how you can trigger. Sometimes they tell me, okay, if I talk to someone, like specifically this person, I will have a seizure. I said, please go ahead. This is the time. So, and I see it. If they tell me, okay, if you don't let me sleep, I will have seizure tomorrow. I do that and they have seizure. So there is no doubt that the stress will lower the seizure threshold. There's no doubt about that. Number one, stress, sleep deprivation, missing medication, dehydration. These four things all known to lower seizure threshold. Then if you rule out missing doses, I will work on that every patient stress individually. So I always give them the encouragement, like, you have to fight it. You have to be optimistic. Let's get you 2 years no seizure first. This is our goal. So I always set a goal. Let's do 6 months no seizures. I want to get you your driver license. I want you to go back to work. I always ask about work. Are you working? Why not? Let's work together. Who's your employer? Let me help you to do that. So I try to see what is the stressful point for them. Oh, I cannot get married. Why? Let's work on that. How we can help you. Is it the seizure itself? Is it the medication? Let me switch the medication if it's they told you cannot do it. So again, try to tailor the answer, how to alleviate the stress based on the question, what kind of stress? Because again, it's not one button of stress. It's different for everyone.
For everyone. I thank you so much for this time. I think this is a topic we need to come back to again and again because it's so relevant and it's so widespread in our communities and it impacts each person uniquely. So thank you to Laine and Erika and Amber and Dr. Shaker. This has been really, really tremendous. And for those of you who have been asking questions, I'm really excited to say that we are about to move into our next panel. We haven't been able to get to all your questions yet, but guess what? You can submit them again because we are about to have an open forum about epilepsy. So thank you to this panel. I'm just absolutely thrilled. And you all in the chat, please let folks know how much you've appreciated this session. And I am going to turn it over to Carla Boyd, one of our board members for the Epilepsy Foundation. She's going to be moderating this open forum where you get to just ask questions for a whole hour. So Carla, I'll hand this off to you.
So again, good morning. My name is Carla Boyd, and I'm very happy to welcome you to the open forum. And I'm also very grateful to serve as a board member at the Epilepsy Foundation of Michigan. But most of all, I'm grateful to be the mother of the remarkable Laine Richards, who you all just met talking about trauma. So this entire conference is for you, but especially this session. This is your time to have extended Q&A with our panel, who will speak about epilepsy based on the many questions you've already brought to the conference. So I'd like to go ahead and present our panel of experts. We have Dr. Tyson Burghardt, who's an adult epileptologist with Sparrow Health System and MSU Neurology. Go Green, and my apologies if you're a Wisconsin fan. Dr. Seth Devries, a pediatric epileptologist with Helen DeVos Children's Hospital. And of course, Renee, who is our community care director with the Epilepsy Foundation of Michigan. So everyone, please join me in welcoming our panelists. And we will go ahead and turn it over to our virtual audience today. So we'll have an extended hour of Q&A where you can share your questions about epilepsy. So think of that question that you've always wanted to ask, or maybe you even have a new one that you learned already this morning as part of our conference. And our panelists will share from their knowledge and experience, discussing innovations, treatments, approaches to care, and more. So again, please use the Q&A feature to ask your questions, and I will facilitate from there, and I can go ahead and kick that off. So doctors, when you're looking at the latest research and advancements in epilepsy treatments, what gives you the most hope for the future? Maybe Dr. Burghardt could start.
Yeah, go White. What's kind of interesting to me is, and just in small pieces so far, but the emergence of treatments for epilepsy in particular syndromes that are very disease driven, because the treatment for epilepsy is very, at least early treatment is very cookie cutter. You've had seizures, here's an anti-seizure medication. Does that work? In half the cases it does. In the other half of the cases we have to try other things. And it kind of doesn't matter to a certain extent what type of epilepsy you have, what's the cause, with minor exceptions, because we kind of go through the same sorts of therapeutic things. But in the past few years, you've seen the emergence of things like fenfluramine for Devries syndrome, and everolimus for tuberous sclerosis, along with metformin now. It seems to be pretty good for that. And, you know, I think some of the drug manufacturers are starting to figure out that putting out just yet another kind of broad spectrum anti-seizure medication when we have 25, 27 of them to choose from already is just not going to do it anymore. And so we need to start finding treatments that are a bit more directed at people's specific disease state. And since we've started to see that just in a little trickle, and I mean, you can get your entire genome sequenced for like $1,800 these days. Like, I see the next 10 to 15 years in that domain being very exciting.
Yeah, that's great. That's actually what I was going to say too. I think we're seeing in so many different disease areas targeted therapies. It's been true in cancer in ways that have actually impacted my family in some pretty big ways. But I think like when we heard Dr. Burdette this morning talking about the ways that neuromodulation can really be tailored and be doing some learning, we're teaching these machines how to respond to individual people. That targeted treatment and that targeted therapy it's really exciting. I think there's a lot of hope there. And the other thing I would say, it's what gives me the most hope, is frankly, this community, and not to be super cheesy, but it's true, because I really watch people take their skills and interests and apply it to advocacy. We're going to be hearing later in the day a panel of people that are talking specifically about how they're getting involved in advocacy. But I look at folks like Miles Levine, who was our keynote speaker for the Wellness and Epilepsy Conference, who is using all of those skills and passions he has around cinema to really address stigma in epilepsy. I know people in this community who are so skilled in using social media to bring awareness to epilepsy. I know people who are such good caregivers in their families, and also members of this epilepsy community that reach out to each other regularly and connect. And so it's really, really meaningful. I also see we have Dr. Devries here, but I think we're having some trouble in being able to see him visually, but hey, there he is. So the question—
I've been a panelist this whole time, but so I'm here.
Yeah, you're here and I'm delighted. The question was, I don't know if you heard that, like what makes you most hopeful in epilepsy care right now, just in terms of innovation?
Yeah, I have to echo what Dr. Burghardt had to say as well. You know, the advancements in both the medications and also with the technology for epilepsy care. Looking at the medications that are coming forward, as Dr. Burghardt said, you know, looking at the everolimus and the cannabidiol, fenfluramine, these medications. For me as a pediatric neurologist, as a pediatric epileptologist, are very exciting because they are in many ways targeting these epilepsy syndromes that have a significant effect on children with very, very significant, profound forms of epilepsy. I want to also add the technology regarding non-pharmacological management, the epilepsy surgery opportunities that are out there now, the neurostimulation, such as a vagus nerve stimulator or responsive neurostimulation, and the way that that brings us even further in our epilepsy care. The advancements that go through with neurostimulation have really just expanded our care exponentially, so that patients who were previously considered not a candidate for neurosurgery, for epilepsy surgery, suddenly they are candidates for surgery, and that is absolutely life-changing for those patients.
Thanks, everyone. We are getting a lot of great questions in. The first one that came in: have there been any advances in memory loss or slowed memory recall related to epilepsy? Dr. Burghardt, do you want to jump in?
Yeah. Unfortunately, like cognitive adverse effects are pretty common, especially folks who might have any temporal, mesial temporal lobe involvement. And I find in my practice that a lot of times it may be more attentional actually than memory per se that people struggle with, either because of the medications themselves, or because of the disease process, or because of whatever thing might have caused their epilepsy in the first place. They have difficulty with focus, difficulty with maintaining attention. And when you can't do that, then your memory also suffers, alongside whatever memory problems can exist from the disease state and medications too. I don't know personally of any sort of major advances in this arena, other than to say, for instance, that like we've not exactly moved on, but I think the old-fashioned temporal lobectomy that could often leave people with a lot of residual memory deficits has become a little less common, and surgical approaches for temporal lobe epilepsy are now a little bit more selective and leave people with fewer deficits without a huge change in the seizure freedom rates. For some of my patients who are not surgical candidates or don't have surgery, or who are controlled but still have cognitive adverse effects from medications or from the epilepsy itself, I often try using low dose psychostimulants, methylphenidate or Adderall, or modafinil even, which is not technically a psychostimulant, to improve focus and attention, wakefulness. And the past few years have shown that using these medications does not actually increase seizure rates among patients. So they appear to be fairly safe and well tolerated. Not everyone gets a good response from that in my experience, but some folks have been able to become much more to be able to fulfill their daily work and life requirements a little better doing something like that. And it's sort of, as an epileptologist at level 3 center, where I don't get to do a whole lot of the fancy cool stuff with surgery and implantations, I focus as much as I can on quality of life improvements by treating the things that come along with epilepsy: anxiety disorders, mood disorders, cognitive disorders. And if you pay attention to those and really go after them aggressively, people do better overall.
Thank you. Dr. Devries, it's great to see you. We got a question in about the amount of medications. My son is on 5 different seizure medications without good control. Is there a time when too many medications can be a seizure trigger?
Yeah, unfortunately, we do know that there are certain medications that, I shouldn't say certain medications. We do know that sometimes anti-seizure medications can actually lead patients to having more seizures instead of reducing it. A classic example for that would be if a patient with a generalized epilepsy, such as absence epilepsy or juvenile myoclonic epislepsy, if a patient with a generalized epilepsy syndrome were to be started on a medicine like oxcarbazepine or trileptal, or carbamazepine, which is Tegretol, those medications target focal seizures. However, if a person with generalized seizures were to receive those medications, there is a theoretical risk that it could actually worsen their seizure burden. Regarding this specific question, right? Your son is on 5 different medications. Seizures aren't getting under good control. That's a challenge. That's absolutely a challenge. Our goal as epileptologists is to get our patients on as few medicines as possible, because every medicine has that risk for side effects, and when there are side effects, quality of life goes down. And so if we're on 5 different medicines, all of which are causing side effects, none of which are causing much benefit, we have to ask that question, what's working, what's not working? When I take care of my patients, and I can only speak as a physician taking care of my patients directly, I can't give personal medical advice for you or your children. But what I can say is that when I'm approached with that very concern, my goal is to figure out what medicines are ineffective and how can we safely wean our patients off of those medications, reducing the side effects and evaluating how that affects the seizure burden itself.
Thank you very much. And while I've got you, we were just talking about neuromodulation. Somebody asked, how well does the RNS work?
RNS, just like anything else, is just like any other medication, just like any other treatment, is somewhat dependent on the patient and the location. Overall, the efficacy of RNS is very, very good. We typically will look at neuromodulation for a patient after a couple of other medications fail. So to give you just a brief understanding of what that means, approximately 2 out of 3 patients will respond to that very first medicine that works for them. Now, if that first medicine fails, there's about a 30% chance, a 20 to 30% chance that the second medicine will work. But if that second medicine fails, now we're looking at about a 10% chance that the third medicine is going to work. And if the third medicine fails, we're looking at about a 1 to 5% chance of the fourth medicine working. And if the fourth medicine fails, we're at a less than 1% chance of the fifth medicine working. So after we got those 2 failed medicines, it's time to start looking at what other options do we have besides medicine. And that's where neuromodulation comes into play. And whether we're looking at vagus nerve stimulator or responsive neurostimulation, it's classically typically considered after 2 or more medicines have failed. Ideally, after that second medicine has failed is when we really start pushing the process and all of that. And the efficacy for those medications, for those treatments, not medicines, but for those treatments ranges between a 50% success rate to a 70 to 80% success rate, which is, when we look at the other alternatives for medicine, that's much better than that 10% success rate that we would have if our patients have already experienced 2 or more failed medications.
Thank you. And Dr. Burghardt, we got a question about depression. Specifically, what is the relationship between epilepsy medication, and depression? What is the best way to treat depression in the context of epilepsy?
So epilepsy and mood disorders, including major depressive disorder, or depression sort of in the broader sense. Mood disorders are more common in folks with epilepsy than in the general population. And the relationship is actually the other way around too. People with mood disorders also have epilepsy at a slightly higher rate than the general population. And it's not always clear exactly why that is. With epilepsy, we're often dealing with, abnormal networks of neurons that are sort of not doing what they're supposed to do. And with mood disorders or sort of psychiatric disorders in general, there's an issue with very broad brain networks and not like a single center that's at fault. And so it's not uncommon at all to have depressive symptoms in folks who have epilepsy, and it can be exacerbated, of course, by the fact that people who have chronic seizures are also at higher risk of being impoverished, of being unhoused, of being discriminated against in employment, and who, because of concomitant cognitive disabilities are also probably a little less likely to be able to navigate systems that still exist, which are not many, but the systems that still exist as social safety nets. And socioeconomic stress is, half of psychiatric pathology in this country. It's not really a quantitative claim on my part, but so all those things considered, the things that we do for folks who have mood disorders and have epilepsy are largely the same things that we would do if you had mood disorders anyway. Counseling is very important. Medications are oftentimes necessary, and we start with some of the basic ones, so-called SSRIs, and then other types, SNRIs. There's a widespread belief among some physicians that antidepressant medications can, quote unquote, lower the seizure threshold and make it more likely for seizures to happen. But with only a few exceptions, most antidepressants are safe at the typical doses being used in terms of seizure burden, and can be pretty effective in decreasing the symptoms of depression. I do what I can, and I reach out to my psychiatrist brethren and sisterin when necessary, when symptoms are very severe, because I know where my expertise ends, so to speak.
And Renee, I know you have a lot to add here. If you could jump in, that would be great.
I mean, one of the things I just want to name, and I almost named this in the last panel too, is like we have been going through years of collective trauma on top of anything individual any one of us is experiencing. And so depression is higher right now. Anxiety is higher right now. PTSD is higher right now. Those kinds of symptoms. And just to be mindful. I mean, one of the things we try to be stigma busters here about epilepsy, but we also need to be stigma busters around mental health needs. And I think a lot how difficult it can be for any of us and people in our community to be dealing with the stigma of epilepsy. And then you want to maybe get some help with that, but you're feeling some tension around the stigma of mental health needs, including some things that maybe you've internalized. And so just to keep normalizing what is frankly normal, that we all have mental health needs and concerns, and we are whole people. So continuing to be not only reactive when we have these kinds of struggles, but proactive too, to make sure that we're doing what we can, both in our own self-care, but also in our wider community care, the professionals we bring in, and the ways that we are addressing. So appreciated that, Dr. Burghardt, like the larger systems that are impacting our lives. Like we've got, and some people being more impacted than others by a lot of systemic harms that happen too. So in all of that, like to take good care and to know that it's okay to need care, because we all do, everybody does.
Great point. Dr. Devries, I think this will be a good question for you because you probably deal with this a little more than the adult side. But we were asked, once on a seizure medication, will you always need to be on medication, or do some people get to safely come off meds at some point?
Absolutely, yeah. Looking at this from a treatment perspective, if a child has, or excuse me, if a person with epilepsy has been seizure-free on meds for at least 2 years, then we start having that conversation of whether or not it's safe to wean off of their medicines. In the realm of pediatric epilepsy, I can say that approximately half of our patients are able to eventually wean off of their meds. And the other half, generally do very, very well, on meds. They might need to stay on meds, lifelong, but they tend to do very, very well. Statistically speaking, after a patient has been seizure-free for at least 2 years on medicine, the risk of having a breakthrough seizure is approximately the same as anybody who, without epilepsy, off medicine. So then we can start having that conversation of weaning them off medicine. Now, again, not everybody will successfully wean off meds, and you know what, that's okay. If you are seizure-free on meds and, and side effects are minimal or non-existent, it's okay to stay on your medicine. You don't have to come off medicines. And quite frankly, I have many patients who when given the opportunity to come off of medicines, their answer is, no, thank you. I'm doing just fine on my medicine. I don't want to have to risk it. I don't want to lose the ability to drive, right? For my patients, they're 16, 17 years old. I just got the chance to drive. I finally got that independence. Now you're telling me that if I come off my medicine, you want me to stop driving for a few months just to make sure it's safe. And then if I have a seizure, I have to stop driving again for another 6 months. No, thank you. Keep me on my medicines. I'm doing fine with that. I'll just keep taking it and live that happy, productive life that I have.
Thank you. And I think this will be a pretty straightforward answer. It kind of ties into what you just talked about. But somebody asked, I received a NeuroPace implant. Can I talk to my doctor about weaning meds?
Again, it all depends on how you're doing from a seizure perspective. One of the great, wonderful things about neurostimulation, NeuroPace and vagus nerve stimulator, is that we frequently are able to, if not wean off meds, at least reduce the medications. And again, it all depends on how we're doing from a seizure perspective. If the seizures are reduced, hey, great news, we can make that happen.
Thank you. Dr. Burghardt, we were asked about how does epilepsy change as the brain ages? In particular, if people who are controlled as they get older can become more at risk for being uncontrolled as they age.
Yeah, I'm struggling with that thing where like it's so complex an issue, but this is a panel, so I got to give you a straightforward answer, I suppose. In my experience, folks who have good seizure control continue to have good seizure control. As long as we expect certain things to happen with normal aging. There are expected changes in how our memory works, in how our thinking works, and we essentially start losing brain volume and neurons from the age of 10 onward, slowly at first, but more rapidly as we get into our older years. Pathological changes in older adults, like the onset of Alzheimer's type dementia or other types of dementia, new strokes, or other sorts of things that tend to happen statistically more likely in older folks, can alter all of those dynamics, of course. But for the most part, folks who have good seizure control will tend to continue to have good seizure control. And when we lose seizure control, some of the first things I look at are, how are they metabolizing their medications? Have other medications been added on that might have drug-drug interactions that have made them less efficacious, and things like that, rather than throw out my hands and go, well, you're older and that's just what happens, because it's not what happens.
And do we see, oh, go ahead, Renee.
Yeah, one of the things I wanted people to know as well is that we, as the Epilepsy Foundation of Michigan, have received this really generous grant from the Michigan Public Health Endowment to do a 2-year large project around older adults and epilepsy and their caregivers. And it's been really, really exciting. And one of the things we are looking at, and we're going to have a workshop about at some point, so stay tuned, are some of these symptoms that take place in older adulthood. Sometimes it can be difficult to know, was that a seizure? Is my memory connected to the memory challenges I'm having connected to the epilepsy, or maybe some other part of aging? Stroke symptoms and the ways those can kind of, strokes causing seizures and seizures being misunderstood as strokes and all of that. And we want to be able to talk about that array of symptoms. And then also for anyone who is 55 and older, or their caregivers, we have a Call and Connect group once a week that is tremendous on Wednesdays from 4 to 5 p.m. every single week, where people really come together and they care for each other. So if you're looking for some support around that, I just want you to know we have a whole group for it. Thanks for letting me interrupt. Sorry.
No, that's perfect. Thank you. And Dr. Burghardt, just to close the loop on this question, someone also jumped in about the relationship between epilepsy and dementia later in life.
Yeah, there's not a necessarily a straightforward cause and effect there. However, folks who are in their 70s and 80s now and who've had epilepsy most of their life, that means that for a large portion of their life with epilepsy, we're probably receiving some of the first generation anti-seizure meds like phenytoin or phenobarbital or carbamazepine. And we know that long-term use of phenytoin or dilantin has deleterious effects on the brain, on peripheral nerves, particularly on coordination, because it makes part of the brain, the cerebellum, shrink. And phenobarbital, when used for long periods of time, can also cause irreversible, usually small scale, but irreversible cognitive decline and brain shrinkage. And so folks who are in their 70s and 80s now are probably on these meds for long periods of their life, and that can certainly contribute at least somewhat to difficulties like that in later life. Having lots of falls, I mean, we understand better now with the CTE issue and the NFL, for instance, that chronic low-grade brain injuries, and low-grade here meaning there's no bleeding inside the brain or things like that, can still have additive effects over long periods of time. And I believe I saw in that question the notion that the person had a lot of falls. It's tough in any one patient to say that this was definitely it. But given the connections we know between some of the medications, chronic brain trauma, and probably for those who've had uncontrolled seizures for large periods of their life, also what that tends to do, you can often say, well, it probably was this or that.
Thank you. Dr. Devries, you probably struggle with this a little bit more than on the adult side as well. And we've definitely gone through this on our epilepsy journey. But the issue of self-reporting, someone had asked, do you envision a future where epilepsy treatment outcomes are no longer necessarily measured in a big part by asking about self-reporting, a patient or caregiver to how many seizures did you have yesterday?
Yeah.
Do you see any technological things there that might help?
Oh man, I hope so. It's hard. It's hard. And I have a lot of empathy for my adult neurology colleagues who don't always, whose patients are not always able to rely on their moms and dads telling them, how many seizures they had. For me, I have a couple of parents who are able to say, oh yeah, well, we saw my child have this many seizures. The school reported a seizure the other day. So there are people who are witnessing a lot of that. But in the end, it does come down to that self-reporting or caregiver reporting. The technology that's out there, I'm going to go ahead and put it this way. A lot of people look at the idea of seizure detection watches, seizure detection apps, detection devices that are out there. The unfortunate fact of the matter is that none of those devices are perfect. None of those devices work for all of our patients. Many times those seizure detection devices either fail to capture seizures or fail to detect seizures, or they create too many false alarms. And so that has been a challenge. So at this moment in time, the technology that's out there is not something that I'm too enthusiastic about. Short of implanting something directly into the brain and measuring brainwave activity, I don't think we have anything that's going to be universally effective. That said, responsive neurostimulation does exactly that. It measures brainwave activity and lets patients know, or lets their providers know whether or not abnormal EEG activity has occurred. That requires surgical implantation though. And so that's not something that I would recommend for the average patient with epilepsy. I hope that technology in the future will have a much more effective universal approach in seizure counting and assessing that seizure burden. Unfortunately, right now, I think it really does come down to the not always reliable method of self-reporting or provider reporting. We do the best we can with what we have.
Got it. And someone had asked about it kind of ties in with the testing question, if there's anything available besides an EEG. But, I did want to personally point out, we had our first home EEG over the holidays, and what a difference. So any comments about testing and EEGs?
Yeah, I think that there's a great example of how technology has really expanded by leaps and bounds. Ambulatory EEGs, EEGs that you can take home, have improved so significantly. Especially over the last couple of years with COVID. Families are not that thrilled about coming to a hospital or coming to a clinic when a COVID pandemic is rampant around the country. And so ambulatory EEGs have really provided a lot of improved options. One of the most important things about an EEG or a continuous EEG is the video feature of it, right? The EEG itself, it's very good for us to get that electrical activity that's happening in the brain. But additionally, it's so important for us to see what the patient is doing, see what is happening to the patient during a seizure or just before the seizure and just after the seizure. And so having access to a video that is linked with the EEG is one of the most important things that we can do. And happily, there are many ambulatory EEG services out there that can provide that that feature, that technology, which, quite honestly, 10 years ago, that did not exist. We had to rely on patients writing a seizure log and just giving us a diary of these are all the things we did. I ate my dinner at 6:10. I finished my dinner at 6:42. I started doing my dishes. Now, as long as they're in the room with the video, usually it's the living room or the bedroom, we can see what they're up to. And that's been a game changer, just like you said.
And Renee, speaking of those diaries, for the times when you're not being monitored, what tools does the Epilepsy Foundation have along those lines?
Yeah, I mean, in terms of like technological, or do you mean just,
Just even like the seizure diaries? I think
yes,
there
we
might be a new one
absolutely
out there.
recommend that. And the Epilepsy Foundation of America is coming up with opportunities. There's a company called Nile that is kind of replacing what we had used as a previous seizure diary. It's something you can check out and look at because it's a little bit more multifaceted. But we do recommend that you think of those things. I mean, self-reporting is not perfect, but sometimes it can be really helpful for you to have that at hand so you can notice your own patterns, right? If seizures are happening at a certain time of day, if they're right after a certain activity, or if it's after a conversation that was remarkably stressful. You can begin to see what those patterns may be for you, particularly, especially if you're newly diagnosed and you don't really know what your triggers may be. And of course, all of that is fluid, and sometimes the seizure just seems to happen and we can't find the pattern, but that can be something that's very, very helpful.
Thank you. And Dr. Devries, I wanted to go back to non-epileptic seizures. I think there's a lot of, it impacts a lot of people in our community, but there's a lot of confusion about that. Like, what is it really? And are the treatments the same as a traditional seizure?
I think that's an absolutely wonderful question. I think it's so important for us to understand non-epileptic seizures, non-epileptic convulsions. I'm going to be very careful with my words here. When I refer to seizures, I refer to the abnormal electrical activity that's happening in the brain. And when I refer to non-epileptic spells or non-epileptic convulsions, the difference is that the episodes of concern can look very similar to a seizure. The patient will experience shaking or unresponsiveness or staring, all of those things that can mimic a seizure, that they look like a seizure. Yet when an EEG is performed, the EEG activity is completely normal. And I think it's so important for us to understand that doesn't make non-epileptic events any less real. They are real. They are a real thing that need to be treated with the appropriate level of care. When a person is having a non-epileptic event, they are not faking it. They are not pretending. They're not crazy. It's just as real as a seizure, even if the epileptic activity is absent, even if the EEG activity is normal. It is still a real thing, and it needs to be treated the proper way. Because we treat seizures, we treat our epileptic seizures with anti-seizure medication. And the purpose of those medicines are essentially to normalize that abnormal brainwave activity. And if we have a patient who's having non-epileptic events, and we give that patient an anti-seizure medication, what we're trying to do is normalize what's already normal. And that's not going to work. All we are going to do is give that person side effects, and that's not fair to them. And, over the last 20 or 30 years, a lot of research has been done on non-epileptic events. And one of the most important things that we have found is that patients with non-epileptic convulsions, non-epileptic events, who are given an anti-seizure medication actually have worsening symptoms. Their symptoms get worse compared to patients whose anti-seizure medications are removed, or patients who are never provided or never prescribed those anti-seizure medications. So then the question comes, what do we do for our patients with non-epileptic events? And that, again, is where the research has really provided us with help and care. And, approximately 95% of the time, those non-epileptic events are related to stress, anxiety, depression, right? And that's a very, very real thing. And it must be treated with the proper therapies. And those proper therapies include working with a counselor, with psychology. It includes addressing our depression needs, maybe with an antidepressant, maybe with an anti-anxiety therapy. But those are incredibly important therapies, treatments for our patients with non-epileptic events. And again, I cannot emphasize enough, they are real, right? And so for anybody who is experiencing non-epileptic events, I'm here to tell you that we believe you. What you're experiencing is real, right? Nobody will take that away from you. It is a real thing, and we have to deal with it the right way.
Thank you. The issue of migraines, which, I've heard since day one of our epilepsy journey about that relation there. So Dr. Burghardt, someone had asked about that very relationship between seizures, migraines, and potentially restless leg syndrome. Are there any meds that can target all of the above?
Yeah. There's just like with mood disorders, there's a bidirectional relationship between migraine and epilepsy. People with epilepsy are at higher risk for having migraine than the general population, and people with migraine are at higher risk of having epilepsy than the general population. And there are these tantalizing biological links that we've known about for decades, because seizures, essentially result from abnormal, hypersynchronized rhythmic electrical activity in the brain. And migraine, or at least the aura of migraine, seems to happen because of a wave of excitation followed by depression of electrical activity over the brain. And so they're like a fast and a slow variant of electrical abnormalities. And in very rare circumstances, you can find folks who have migralepsy. I've only ever seen one case that really fits the bill, but these are folks who have seizures that are essentially triggered by migraine aura attacks. And so you have this sort of double whammy. And so as a result, several anti-seizure medications, because anti-seizure medications don't really form a single group. There are all sorts of different structures, different kinds of molecules that target different things in the brain, but they all happen to reduce seizures. And so it's not a surprise, since there's electrical phenomena going on with both disorders, that some of these medications can treat both. Lamotrigine, topiramate, zonisamide are very often used for migraine prophylaxis, and people sometimes use some other valproate, although we tend not to use that in people who could become pregnant for I hope obvious reasons. These are all can be quite effective in many folks, and sometimes gabapentin as well. Every time I think I've thought of all of them, there's another one that pops in my head. The burden of migraine is so great in some parts of the population that we're willing to kind of try anything once we've exhausted the other stuff. And carbamazepine and oxcarbazepine, how did I not think of those as well? So yeah, there's plenty of the work on both. As far as restless leg syndrome, I'm not aware of any mechanistic link between epilepsy and restless leg per se. Sometimes folks have restless legs because of a deficiency in B vitamins, sometimes because of iron deficiency, particularly women who might have heavy menses, or B vitamins, lack of B vitamins can also cause anemias. But sometimes that also happens without any real known cause. And although it's often treated with dopamine agonists, things that are also used to treat Parkinson's, but not epilepsy, another potentially useful treatment is clonazepam, a benzodiazepine, which we don't typically use to treat epilepsy because people tend to become, the epilepsy tends to become tolerant to its effects, but sometimes can be a useful adjunct.
Thank you. Dr. Devries, I'm going to combine a couple of questions here. Someone had asked about the timing of testing, and I wanted to focus on the genetic aspect. Really the best time to do that genetic testing, if it's kind of a standard that you all are doing now. And then someone had also asked someone with epilepsy, they've gotten conflicting advice as to the likelihood of their children, if they were to have kids, developing epilepsy.
Yeah, epilepsy genetics is an up and coming field. There's more and more information that's coming forward with all of that. It's exploding. As a nerdy epileptologist, I think that's awesome. I geek out about this quite a bit. Just the number of different types of epilepsy genes that we are identifying and diagnosing, and and providing guidance on with patients and families. It's a challenge to look at what is the timing. You know, when I'm taking care of a patient with epilepsy, I'm looking at more than just their seizures. I'm also evaluating their mental status, their cognition. Are they experiencing developmental delay? You know, in addition to the family history, is there a family history of epilepsy? Is there a family history of a developmental delay and cognitive impairment? All of these things come together when we make the decision of how aggressive do we need to be with genetic testing in our patients. It's very important to know the patient's story. There's no set standard on when do we perform genetic testing. It's all about the patient's story. And I think that's one of the most important reasons why I recommend connecting with an epileptologist for your epilepsy treatment, because of the nuances that come with understanding the story and knowing where to go with that. If I can just give just a brief example, and I'm kind of pulling this off from the top of my head. If I were to see a newborn baby who was suffering from severe seizures numerous times a day, and I saw a certain pattern on the EEG that showed seizure after seizure after seizure, for example. Based on that information, I would immediately get genetic testing for that newborn baby, because I'm listening to the story of what's going on, because I'm paying attention to that patient's story. On the other hand, if I had a patient who is 15 years old and had one seizure in their lifetime and then had another seizure 8 months later, okay, and there's no family history of epilepsy, and they are they're treated with an anti-seizure medication, and that medicine is working very, very well, I would probably not pursue genetic testing for that patient, because based on that story, genetic testing isn't going to provide additional information that's going to impact my patient's care. I know that I'm kind of dancing around the question, and I think ultimately I have to, because as an epileptologist, I've got to take each case and frankly take it on a case-by-case basis.
And I will point out, because I just learned this recently, if you are considering genetic testing, insurance will stop covering that when your child turns 18. So just something to keep in mind. And Dr. Devries, while I still have you, neurofeedback, you know, some controversy around that, kind of considered an alternative treatment. What are your thoughts on that?
So that's a great question. There's a difference between neurofeedback and biofeedback. So biofeedback is the process of working essentially on meditation, deep breathing, working very much on kind of mindfulness. And there's a lot of science behind biofeedback. We know that when we are looking at our deep breathing exercises, the yoga and that whole process, we are, essentially able to help transition our body into a parasympathetic response, which is that relaxed response that the body can benefit from. Neurofeedback does not have much science behind it. My understanding of neurofeedback is that it is the process of measuring brainwave activities while a patient is engaged in various activities, which may or may not include some of those deep breathing exercises. And somebody is reviewing that EEG and making decisions based on that EEG. What I do know is that somebody who's reading the EEG is rarely a neurologist, rarely an epileptologist. I don't want to say never, because never say never, but I do not know of any neurologists or epileptologists who read EEGs for neurofeedback. So I think it's very important to take any of the information that's given from neurofeedback with a pretty big grain of salt, if you will. That being said, my philosophy on some of these, if you will, alternative medicines, these alternative treatments is as long as that alternative treatment is not causing harm to you or your child, if you feel like it is providing you with benefits, I'm not going to tell you not to do it. On the other hand, if it's not helping you, then don't waste your money. If that alternative treatment is causing harm, I will say without a doubt, stop doing it. And there are certain treatments out there that people have peddled to desperate families, desperate parents, which do cause harm. And I will say to my families, to my patients, stop that. But if it's not harmful, if it's not harming you or your child, and you feel like you're getting benefit out of that, you know what? All right, go for it. Let us know. Let us know as your neurologist, as your providers, as your physicians, as your care providers. Let us know that you're doing it, because we want to know about that stuff. We want to learn about that as well. I always miscredit the quote here. There's a comedian that said at one point, and I'm not going to say it quite right. When we use evidence-based research to show that alternative medicine works, we call it medicine. So there is something to that, and I know I'm botching the quote. I don't know if anyone knows that quote. I'd love to post it in the chat, because I love that quote. Apparently not enough to to know it word for word, but it's a great quote.
Our next session today is entitled Studying SUDEP, Biomarker Research and Seizure Alert Systems. And here to present to you today is Dr. Julie Ziobro, an epileptologist with Michigan Medicine. SUDEP stands for Sudden Unexpected Death in Epilepsy. And I want to acknowledge that, like our trauma panel earlier today, this is a difficult topic in our community. And it can, of course, produce anxiety in us. And for some families who have lost loved ones, this topic is a reminder of painful grief and loss. So with that in mind, we want to enter this topic with care today. And if you need to pause or take breaks, that is honored and welcomed. The session is ultimately about preventing SUDEP. So with that, it brings great hope as well. And before Dr. Ziobro begins, I want to share, if you are a family member or a friend of someone who has lost a loved one to SUDEP, we are here for you, and we send you our deepest condolences and support. And I also want to provide you with resources for connection, support, and encouragement. The SUDEP Institute of the Epilepsy Foundation of America is a great organization for connection and care. And likewise, the Cameron Boyce Foundation and the Danny Did Foundation are doing tremendous public education to teach people about SUDEP and its prevention. So if at any time you would like us to connect you to these organizations, you can contact us. But also, we are here in support for you as well, and we want to listen to you, honor your loved ones, and uphold their memory in conversation and care with you. We're also offering a virtual remembrance wall of these loved ones for our Strolls for Epilepsy this summer. So you can call us anytime at 1-800-377-6226. And now it is my honor to introduce Dr. Ziobro. Dr. Ziobro is a pediatric epileptologist and clinical assistant professor of pediatrics at the University of Michigan. She's a clinician scientist with clinical and science research interests in understanding the mechanisms of genetic epilepsies to improve treatment outcomes. So please join me in welcoming her. Dr. Ziobro, thank you for your presentation today.
Thank you so much for the introduction, Renee. Can you guys see my screen, and does it look like it's supposed to look?
Yeah, it looks great.
Okay.
It looks
great.
actually, sorry, it looks like you're on the presentation side of it.
Oh,
and
I
not-
am on the wrong side. Sorry.
Yep.
After 2 years of Zoom, you would think I would figure this out by now.
We're all doing these things.
Okay. Does that look like the correct view now?
Yes.
Okay, great. Thank you for the introduction, and thank you all for being here. And I am so glad Renee acknowledged that this is a very sensitive topic, and I will try and present it more from a research aspect, but certainly this is something that families should be talking with your epileptologist about, and support foundations like the Epilepsy Foundation as well. So today I'm going to talk a little bit about studying SUDEP, looking specifically at some biomarker research and seizure alert systems. I am a pediatric epileptologist at Michigan Medicine, and as Renee alluded to, I have a special interest in basic science research, particularly in genetic epilepsies. And I'll touch a little bit on some genetic epilepsies today, but I was hoping to keep the topic broad so that hopefully everyone can get something from this. So today I'm going to be talking a little bit about what SUDEP is, and then trying to define maybe what we know about risks for SUDEP, looking specifically at biomarkers in studies from both human and animal models. And then I know people want to know a lot about seizure detection devices, so we will touch on them a little bit, what they are, how they work, and then giving you a few examples of them. And then of course, what we know about potential prevention of SUDEP. There are a lot of definitions when it comes to the SUDEP literature, and some of them are a little bit complicated. But as Renee pointed out, that SUDEP is considered sudden, unexpected death in patients with epilepsy. And it must be sudden, unexpected. It can be witnessed or unwitnessed. It must be non-traumatic, and it must be a non-drowning death. And not every case of SUDEP has evidence for a terminal seizure that occurred in the individual with epilepsy. SUDEP does not include documented cases of status epilepticus. So patients with definite SUDEP, SUDEP is when the postmortem examination fails to reveal another cause of death. Probable SUDEP is when patients don't have a postmortem examination, or the victim died unexpectedly while they were otherwise in a reasonable state of health. Near SUDEP is in cases in which the patient had a cardiopulmonary arrest, and there was no structural cause identified after the investigation. However, the patient survived for more than an hour after that arrest. And then fatal near SUDEP is where they may have survived for an hour after that arrest, but then ultimately succumbed. And then there are other definitions of possible SUDEP versus SUDEP plus, in which patients may have had a competing cause of death where it's really unclear, or in SUDEP plus where SUDEP criteria is met, but there may be evidence for other coexisting conditions that may have contributed to their death. So as you can see already, this is getting messy, and SUDEP is a very difficult thing to study, but it's a very important thing to study because we need to get to the causes of why SUDEP happens. We've known about SUDEP for a long time. Sudden death in epilepsy has been recognized and reported in medical literature since in the 19th century. So Dr. Bacon reported this in 1868, was the first kind of medical case report of SUDEP. However, George Washington actually experienced SUDEP in his family. So this is George Washington's stepdaughter, Patsy Custis, and she passed of possible SUDEP when she was a child. And he wrote about this in 1773 in his diaries, and stated that she rose from dinner about 4 o'clock in better health and spirits than she appeared to have been in some time, soon after which she seized with one of her usual fits and expired in it in less than 2 minutes, without uttering a word, a groan, or a scarce sigh. This sudden and unexpected blow I scarce needed has reduced my poor wife to the lowest ebb of misery. And I think that expresses a lot of what concerns all patients and providers and parents surrounding patients with epilepsy when they're concerned about SUDEP. SUDEP was kind of largely ignored as something to study in the medical literature and didn't really have professional attention in the US prior to the mid-2000s. And then fantastic organizations such as Partners Against Mortality and Epilepsy was started in 2014, and they've supported quite a bit of research in the SUDEP field, which is gaining more attention from both a basic science and a clinical science perspective. SUDEP is relatively rare. However, it is thought to be contributing to death in patients in 7 to 17% of deaths in patients with epilepsy. And this study looked at kind of the proportion of SUDEP as patients get older. And the question is if this actually does, if SUDEP really does decrease as patients get older, or is it just getting attributed to other medical comorbidities that patients may have as they age? The reported annual incidence of SUDEP is about 1.16 cases per 1,000 people with epilepsy. So about 1 in 1,000 persons with epilepsy is at risk for SUDEP. However, SUDEP is responsible for a very high number of years of potential life loss, and it's second only to stroke for the number of years of potential life loss. The cumulative risk of SUDEP may be related to the age of onset of epilepsy. So in patients who have epilepsy onset at less than, or at 1 year of age or less, then it's estimated to be about 8% for their lifetime, versus 7.2% in patients who have onset at 15 years and 4.6% for patients who have epilepsy onset at 30 years. Of course, some of these things are very difficult to study for all the reasons you might imagine. So gathering this data when a family's experienced such a traumatic event is really difficult, and research is really the last thing that the patients or their families or their physicians are thinking about at that time. So we know that some of this is probably largely underreported. And Renee had mentioned the Cameron Boyce Foundation. So when we think about who's at risk for SUDEP, unfortunately, SUDEP can happen at any age to anyone, and even famous people. So Cameron Boyce was an actor who died at age 20 on July 6th of 2019. He's well known amongst my adolescent patients, and I know after his death, many of my patients kind of asked me more questions about SUDEP because this is something that was weighed heavy on their minds. The LA County Department of the Medical Examiner, the coroner at that time, did find that the cause of death for Cameron Boyce was a sudden unexpected death in epilepsy, and his family's gone on to start the Cameron Boyce Foundation as well. Risk factors that we know of for SUDEP, it seems that males seem to be at higher risk than females. We know that duration of epilepsy can play a role in the risk of SUDEP, and that age of epilepsy onset, like we talked about before, increases your risk. So patients who had epilepsy onset at less than 16 years of age are at a higher risk for patients who had adult onset epilepsy. Symptomatic epilepsy, so epilepsy that's known from a brain injury or brain disease, is more likely to be related to SUDEP. And then patients with tonic-clonic seizures, especially nocturnal tonic-clonic seizures. This is really the big contributing factor. We know that patients who have 1 to 2 generalized tonic-clonic seizures per year, that increases their odds ratio for SUDEP by up to 5 times. And patients who have more than 2 generalized tonic-clonic seizures per year increases their odds ratio by more than 15 times for SUDEP. There have been plenty of postmortem studies that have found other factors that don't necessarily, or haven't had determined significance in playing a role in SUDEP. And that includes things like the frequency of seizures of any type, if they've had seizures within the past year, if they're on polypharmacy, meaning multiple medications, or if there's any specific medications that may be more associated with SUDEP. There have been some postmortem studies that have found a relatively high percent of SUDEP cases in which the patients had no identifiable anti-epileptic medication levels within their system, which would suggest that maybe they weren't taking their medications as prescribed, or maybe they didn't have medications. We do have some practice guidelines when it comes to SUDEP and SUDEP discussion. So the AAN, American Academy of Neurology, and American Epilepsy Society have practice guidelines basically stating that physicians should be talking with their patients about SUDEP. And based on a systematic review in 2017, it was determined that the incidence is 1.2 per 1,000 patient years in adults. And at that time, it was reported to be 0.22 per 1,000 or 1 per 4,500 patient years in children. However, we have since learned that some of that is probably because these numbers are underreported in children. So there's newer studies that suggest a overall incidence of about 1.45 per 1,000 patient years. And this is not largely different depending on age, though it's still slightly lower in the patients, say, ages 0 to 16 than it is in patients who are older than 50 years. A special plug for specific syndromes, and this is specifically about Dravet syndrome. So many of you may know that Dravet syndrome is a genetic epilepsy. It's caused by a specific pathogenic variant in a sodium channel gene, SCN1A. Dravet syndrome itself is often characterized by frequent episodes of status epilepticus and the setting of fever, and patients also have developmental delays. Patients with Dravet syndrome have a relatively high risk of mortality related to Dravet syndrome, anywhere from 3.7 to 17%, depending on which studies you read. But amongst those, SUDEP-related deaths occur in 53 to 61% of those patients who die with Dravet syndrome. This is quite high compared to a matched cohort of 14.5% of patients with new onset epilepsy who succumb to SUDEP as opposed to other causes of death. We also know that patients with Dravet syndrome have an increased risk of status epilepticus and nocturnal seizures. So this is a particular interest of mine, and a field that has been studied is how we are preventing SUDEP in Dravet syndrome. And some of these things may be translated into other forms of epilepsy as well. So in thinking about mechanisms of SUDEP, looking at some basic science, there are a few things that basic science has shown us or tried to teach us, or we've tried to learn from basic science. And this is really a specific interest of mine, is how do we take data that we obtain from mice and rats or cells in a dish and translate that to humans. So I'll go through a couple of studies that we know about, that I've read about, looking at abnormalities in cardiac function, autonomic function, and then there's one particular study looking at laryngospasm, which may be relate to respiratory function as well. So this was a rat model looking at cardiac changes that are associated with seizures alone. And this was just published last year. And this is a interesting model to me because I've known about this model for epilepsy for a long time, but I don't know that anyone has ever looked at cardiac function in these rats before. So in this study, the researchers used cyanuric acid, which is a proconvulsant. And when you give it to a rat, it causes them to go into status epilepticus. The rats would then be rescued from that status epilepticus, and a proportion of the rats would go on to develop spontaneous recurrent seizures or have acquired epilepsy within the weeks after that initial insult. So the researchers actually were then looking at the hearts of these rats, and they did an echocardiogram prior to their status epilepticus, and then they monitored them for several weeks with serial echocardiograms. So they also did 2 weeks of simultaneous EEG and EKG recordings so that they could look at other measures of heart function, in addition to looking at the number of seizures that these rats had. So the interesting thing that they found was that in the rats who had more seizures, so the rats who were having up to 10 seizures per day, after the study was over, they looked at their hearts and found that there was a significant amount of fibrosis within the heart of those rats. This was compared to the other rats who only had 1 seizure per day, and they did not have quite as much fibrosis. When they had done the echocardiograms, they also found that that fibrosis related to abnormal heart function as well. So the ejection fraction, or the amount of blood that the heart was pumping, was significantly decreased in the rats who had more seizures and therefore more fibrosis. Now, this may relate to what we know about people with epilepsy who have a higher risk of cardiac abnormalities as well. So there's been a few studies. This was a literature review looking at the SUDEP literature, and amongst this review, they found that cardiac abnormalities were found in approximately a quarter of all cases of SUDEP. And amongst those abnormalities, it was things similar to what they saw in the rat, including interstitial fibrosis, so fibrosis within the heart, cardiac hypertrophy, so an enlarged heart, and then other fibrotic changes of the cardiac conductive system, which may play a role in how the heart is beating and potentially cause arrhythmias. This was another study where people with epilepsy had echocardiograms, and they found a significant number of abnormalities in persons with epilepsy compared to their age-matched controls, suggesting that having epilepsy alone may be a cardiac risk factor. We know from some of our mouse models that cardiac arrhythmias may actually play a role in SUDEP. So this particular model is one that's developed here at the University of Michigan by some of my colleagues, so particularly Miriam Meisler and Laurie Isom, who I work closely with in the lab. This mouse model uses an SCN8A, so a sodium channel gene that is responsible for epileptic encephalopathy in some patients. And they look particularly at cardiac arrhythmias in these mice as well. These mice tend to die of a single fatal seizure, and we can't always predict when that happens. So in order to look at changes that may happen with seizures, they actually sedated the mice to be able to get these very nice EKG recordings. And then they gave them caffeine to kind of simulate some of the catecholamine release that might happen when you have a seizure. And they found that that induced a significant number of arrhythmias in these mice. In addition, they were able to do some heart rate monitoring, kind of long-term heart rate monitoring in these mice. And yes, 600 beats per minute is a normal mouse heart rate, but they were able to see that within 36 hours before the mouse had their fatal seizure, their heart rate actually dipped significantly, suggesting that they were developing some cardiac arrhythmias and cardiac abnormalities before they died from their final fatal seizure. Another study that's been done by Dr. Isom's group, along with my mentor, Jack Parent, involved actually samples from a patient. So in this particular patient, they had another sodium channel gene abnormality called SCN1B, and had symptoms that were significant for Dravet syndrome. The researchers actually took skin cells and then reprogrammed them into stem cells. And some of you may know that stem cells, then we can kind of program them in a dish to turn into all different types of cells. So we can make them turn into neuron cells, like the brain type cells. We can also turn them into cardiac cells. So when these were programmed into cardiac cells and then cultured in a dish, they actually start beating on their own, which is really pretty cool. So hopefully this comes up well out over Zoom, but the cells on the right, this is the heart cells in a dish that were derived from the patient samples. And the ones on the left are heart cells in a dish that were from a control patient, a patient that does not have epilepsy. And you may be able to appreciate on here that these cells are beating much more erratically from the patient line versus the ones from the control line, which kind of have a nice rhythmic beating. And if you watch it for a while, there's some times where the patient line gets some really kind of abnormal and not fluid beats, which would suggest that they may be at risk for an arrhythmia. So I will tell you, my colleagues were actually quite disturbed when they saw this in a dish, and they recommended that the patient undergo evaluation by cardiology. So the patient then had a cardiac exam and then had findings on their echocardiogram and Holter monitors that showed that they had evidence of a dysrhythmia or arrhythmias on their EKG, and they had some abnormal short-term variability on their Holter monitors, so that they're being monitored really closely by cardiology at this point. Now, again, this is evidence that people with epilepsy may have a higher risk of cardiac problems, but it doesn't necessarily relate it to a cause of SUDEP. Sorry. And I touched on that term heart rate variability. So this is something else that the researchers have looked into as a potential cause for SUDEP or a potential underlying risk factor. When we think about heart rate variability is the neural cardiac control. So it's the way that your brain is altering your heart's beating. So it's the kind of thing that tells your heart to beat faster when you are going for a run versus telling your heart to slow down while you're sleeping. And in this patient, or in this study from 2015, the researchers had essentially tried to look at different risk factors patients had for SUDEP using this score called the SUDEP-7. And they tried to correlate that with the patient's heart rate variability on Holter monitoring. And they found that the patients that had lower heart rate variability, meaning that their heart rates didn't change as much when they went through things like running versus going to sleep. If they had lower heart rate variability, it actually correlated with having a higher risk score for SUDEP. However, these patients did not have SUDEP, they just had these increased risk factors. But it did potentially suggest that there is some component of autonomic tone that may be related to risk for SUDEP. This was a mouse study that maybe doesn't relate to anything, but I thought it was kind of interesting. So there's a particular genetic line of mice called the DBA2J mice that have these very easily produced lethal audiogenic seizures. So it means researchers can play a loud sound, and then all mice will have seizures, and for most of them, it causes them, or it is a lethal seizure. When these mice were being studied, it was found that they tended to die from respiratory arrest, and eventually it was found that they were actually having laryngospasm, meaning that with the increased tone of the seizure, they were having their throats were essentially being closed, and they weren't able to breathe appropriately. So to get around this, the researchers tried to implant these little tracheal tubes, so essentially like a little tracheostomy that bypassed the larynx, and they were able to increase the survival by preventing this airway obstruction, which kind of suggests that the respiratory drive, so the body's desire to continue breathing, or the brain's desire to continue breathing, was still there, and that it was actually this laryngospasm that was causing them to not have enough respiratory drive. So this maybe doesn't have anything to do with human literature, but I think it's something we need to think about when we're trying to understand what happens during SUDEP. In SUDEP studies in humans, we have tried to look at different mechanisms, but right now most of these things are associations, and we don't necessarily have a one-size-fits-all cause for SUDEP or one-size-fits-all prevention for SUDEP. There are some things that have been pointed to as potential changes that we've seen in patients who are at high risk of SUDEP, but it's likely multifactorial. The quest for biomarkers in SUDEP has been ongoing for a long time. Biomarkers are essentially a way that we have been attempting to identify those that are at risk of SUDEP, and then ideally trying to modify those risks. So this is actually that SUDEP 7 score that I had talked about, where you get a higher number of points for each of these risk factor things. In particular, more than 3 tonic-clonic seizures in the past year gets you a score of 2 versus a score of 0 if you haven't had that. And then, based on how long you've had epilepsy, you may have a higher score, et cetera. In addition, some of these things that have been used in research include the heart rate variability, like we talked about, and then looking at things like periictal cerebral oxygenation, so kind of your oxygen saturation after a seizure, and PGES, which is an acronym for post-ictal generalized EEG suppression, which is something that has been studied in the EMU. In looking at some of these biomarkers and factors in patients who had known SUDEPs, and compare them to matched living controls of patients who also have epilepsy. This was a study that looked at 18 patients with SUDEP compared to 48 controls, and tried to identify different factors that may have been contributing to their SUDEP. All of these patients had undergone EEG monitoring in the EMU, so there were things that we could look at surrounding their seizures to see if there was something that was more common among the patients who had an eventual SUDEP. Among these, the only thing that came out significant was this PGES, so the post-ictal generalized suppression on their EEG was more common in the patients who eventually had SUDEP versus the controls. Looking at other things like their SUDEP 7 score, that score that I just talked about, it was not significantly different between the patients who had SUDEP and the controls. So we like to think that that may be a reasonable tool to use. However, at least in this very small study, it was not found to be a significantly useful tool. Generalized post-ictal EEG suppression, or PGES, like we talked about before. This is kind of what it looks like on an EEG. And this EEG shows a patient who has a generalized tonic-clonic seizure, and then they have this very suppressed background on their EEG following the seizure before normal brain activity returns. And this is a finding that, at least from that study and several others, has actually been found to be more common among patients who would subsequently die from SUDEP. I'm sorry. Just as an aside, PGS has also been associated with other post-ictal physiologic disturbances. So things like enhanced electrodermal skin response, which is indicative of maybe increased sympathetic nervous system activity, in addition to post-ictal hypoxia, so decreased oxygen saturations after a seizure. It's also been associated with post-ictal cardiac arrhythmias, so changes in heart rate and heart rhythms following a seizure, and also in patients who have post-ictal coma and immobility. Mortimus was a landmark study that was published at the end of 2013, and it was a descriptive study of case reviews of witness cardiopulmonary arrest in the EMU. So this is Mortality and Epilepsy Monitoring Unit study. As you can imagine, mortality in the EMU is a very rare event, and this was a study that involved multiple different countries and continents. So it was a retrospective study in which there were 16 patients of SUDEP, 16 patients who succumbed to SUDEP throughout the world. So it was in patients in Europe, New Zealand, Israel, Australia, the US, and India. Among those 16 patients, 10 of them had sufficient data to be informative of what potentially led to SUDEP. If you look on these graphs, they're a little bit hard to look at, but this is each of the patients. And on the top, they looked at variations in the respirations and then variations on their electrocardiogram as well. And the light blue pattern here is transient apnea, so meaning a period where they stopped breathing. The dark blue would be their terminal apnea, so essentially when the patient stopped breathing prior to SUDEP. In addition, looking at the heart rate monitoring, the violet and maroon are suggesting bradycardia, so when their heart rate decreases, followed by asystole in the maroon, so when their heart stopped. And the thing that came most out of the study was that in all of these patients, there was a specific pattern prior to SUDEP in which there was this rapid breathing where patients were breathing between 18 and 50 times per minute. And that was also associated with PGES on their EEG. In addition, in all the patients, they were noted to have cardiorespiratory dysfunction within the first 3 minutes following their seizure. And the terminal apnea was always preceded the terminal asystole. So they all had respiratory dysfunction prior to heart dysfunction. So it maybe informed us a little bit about how SUDEP happened, but it, again, doesn't necessarily give us great insight into how we prevent it. We know that respiratory dysfunction can be really common in patients with seizures, especially in patients with focal epilepsy, and that ictal central apneas can occur in up to 30 to 40% of patients with focal seizures. This is likely due to seizures spreading to those regions of the brain in the brainstem that control breathing. But ictal apnea itself is almost always self-limited. However, post-ictal central apnea, so the apnea that follows generalized tonic-clonic seizures, can be really common as well. So in 18 to 22% of patients with generalized tonic-clonic seizures in an EMU. Researchers have also looked at different parts of the brain to see if any MRI signals can give us an idea of who may be at risk for SUDEP. In cerebral morphology, they found some areas that seem to have increased volumes, including in the right hippocampus, parahippocampus, and the amygdala. However, they found other areas that have decreased volumes, so specifically in the thalamic pulvinar. Now, this may be a little bit of a chicken or egg situation because the severity of the volume loss actually correlated with the epilepsy duration. And we know that patients who have epilepsy for longer periods of time may have lower cerebral volume to begin with. In addition, they found that there's been brainstem volume loss in patients who may have been at risk of SUDEP. And we know that the brainstem plays a really important function in controlling things like cardiac and respiratory function. Now, in looking specifically at the brain-heart connection, there are a lot of different outflows that go back and forth between the brain and the heart. So cortical areas and subcortical areas, so amongst this part of the cortex of the brain and these subcortical areas, there's many of them that are related to cardiac function, and they influence the autonomic nervous system, which is the nervous system that helps to control cardiac function. We also know that there's feedback that comes from the heart that actually returns back to the brain, and that may actually activate these neurocardiac reflexes as well. And we know that results from animal models suggest that some of these altered neurocardiac connections could ultimately represent risk factors for SUDEP as well. Now, among these, looking at different phases of seizures and what the cardiac risks are, in the interictal phase, when somebody's not having seizures, we know that patients with epilepsy have a higher risk of arrhythmias, and they may actually have more risk factors for myocardial ischemia as well. During these pre-ictal phases, patients often have heart rate elevations, which again may lead to cardiac risk factors. In addition to their ictal phase, where there's even more heart rate elevations, and we've seen electrocardiogram alterations, including things like bradycardia, AV block, and asystole. The authors of this paper brought up a really interesting syndrome called Takotsubo syndrome, which I don't know if anyone's ever heard of, but this may be, it's a very rare syndrome, but it's actually referred to as broken heart syndrome. It's a really rare disorder in which a stressor can cause acute heart dysfunction. And we know that among the stressors, neurologic disorders such as stroke and seizures are actually most frequently associated with TTS, but it can actually be secondary to other things like severe grief. So that's why it's considered or called broken heart syndrome. It's thought that this is related to associated catecholamine release that may happen during things like stroke and seizure or in severe emotional distress. And the question is this related to potential cardiac abnormalities that may eventually be related to SUDEP? This is a really rare syndrome, and it's probably underestimated because it's not always looked for. And there's really not enough evidence right now to link it to SUDEP, but it kind of raises this question if neuronal control of heart function may be an ultimate risk factor for SUDEP. I talked a little bit about autonomic dysfunction, and this is just a quick diagram to demonstrate how much autonomic function, meaning function of the respiratory system, the cardiac system, and things like neurohormones are released related to brain dysfunction as well. And there's multiple areas of the brain that have links to all those other body symptoms as well. We know that there's an ictal autonomic response, and this is seen most commonly in patients with focal epilepsies, especially from the temporal lobe, that these temporal lobe, or that seizures can have a lot of different autonomic effects. So when patients have things like heart rate increases, or some patients will describe other gastrointestinal features of their seizures and things like that, we know that they are related to autonomic dysfunction directly from the temporal lobe. A lot of these other autonomic dysfunction can increase your risk of SUDEP based on some other underlying factors as well. So it continues to raise more questions about how the brain controls the rest of the body. And finally, we know that there are genetic causes that may be related to SUDEP. So this was amongst a review of patients who had SUDEP and looking for other genetic abnormalities. And in genetic screening testing from patients with SUDEP, there seemed to be a high incidence of patients who had underlying genetic disorders in genes in potassium and sodium channel genes, both those that are present in high quantities in the heart, and then those that are also present in the brain. In addition, some of these are present in both. So SCN1A genes are also expressed in the heart, though not as highly as in the brain. And same with SCN5A genes are expressed highly in the heart and less so in the brain. However, they may both be related to epilepsy, and they both may be related to cardiac dysfunction as well. There's a bunch of other candidate genes that are being identified that may be risk factors for SUDEP as well. And this was a total of 86 cases of SUDEP that have been identified to have pathogenic genetic variants. However, I have to emphasize that there's a lot of caution when studying SUDEP in humans, because we know that there's limitations to studying these post-ictal phenomenon. Importantly, not all SUDEPs occur in the setting of seizures, so this is probably not a one-size-fits-all phenomenon. And the patients that we have data on are those that were being observed in the EMU, and those are not necessarily the same as every patient who with epilepsy. We know that patients who are observed in the EMU often have drug-resistant epilepsy, and they often have focal epilepsy, and that's why they are in the EMU to be monitored as potential seizure surgery candidates. But SUDEP can happen across all epilepsy types, and we worry that some of the EMU studies that we have may be limiting our ability to study SUDEP appropriately. SUDEP prevention is a difficult thing because we don't, again, know all of the risk factors. However, I know somebody's going to ask about cardiac monitoring, considering the things I just talked about. I would say at this point, cardiac monitoring may be recommended for high-risk individuals. Now, what are high-risk individuals? So we don't have guidelines on this yet, but I think there is a place for cardiac monitoring, or at least cardiac evaluation, in patients who have had epilepsy for a long period of time, or if you have some of those other risk factors, including a high frequency of generalized tonic-clonic seizures, and certainly in patients with genetic risk factors. All of my patients with Dravet syndrome have a cardiac evaluation. Long-term studies of a large cohort of patients where they use this loop recorder implants. So they're little implantable devices that can look for arrhythmias for up to 2 years. And this was looking at patients with focal epilepsy. They had these loop recorders implanted for 2 years, and they didn't find any clinically relevant arrhythmias in patients with refractory focal epilepsy, which suggests that maybe some of the things I've said have been overblown and that we don't actually have evidence for this in humans at this point. Treatments. So how can we prevent SUDEP? Interestingly, there's been some data, especially in rodent studies right now, pointing to effects of SSRIs. So in a similar, or in a mouse study where they use this DBA1 mouse model of SUDEP, they found that an SSRI completely suppressed seizure-induced respiratory arrest at 30 minutes after administration without blocking the audiogenic seizures. So those are the mice that had seizures when you played the loud sound, and they were able to avoid SUDEP if they were administered an SSRI, so an antidepressant medication. Looking at different devices, so patients with refractory epilepsy who have treatment with either VNS, RNS, or DBS may be able to obtain better seizure control and thereby decrease their risk of seizures as well. And then we know that nursing intervention and nocturnal supervision from things like the Mortimer study, they can also be preventative for SUDEP as well. However, not every patient is monitored by nurses 100% of the time, and certainly adults who live alone are not monitored and have nocturnal supervision all the time. So it raises the question if seizure monitoring devices may be useful, and we'll get to a little bit of that at the end. In talking about seizure control, surgery is certainly something that many patients with focal epilepsy should consider along with their physician. So in 2016, this neurology paper reported that from 1986 to 2013, there was a finding that overall mortality was 8.6 per 1,000 person years, compared to 25.3 per 1,000 person years. It was more frequent postoperative tonic-clonic seizures were greater than 2 per year, were associated with increased mortality, where focal seizures were not related to the death rate. So essentially saying that patients who had epilepsy surgery had a decreased risk of SUDEP. Looking at neurotransmitters, kind of back to that previous study, so should all patients be on an SSRI? I don't think this is necessarily the way, but certainly if you have comorbid depression and could be potentially treated by an SSRI, the data is still out if this could potentially prevent SUDEP as well. So we know that serotonergic pathways, so 5-HT, receptors are in the brainstem, and they're important for respiratory, sleep, and chemosensory responses to excess carbon dioxide, which is what your body makes when it's not breathing appropriately. So essentially, those brainstem centers are what help those autonomic functions to work appropriately. We know that SSRIs and a new drug called fenfluramine can actually enhance the serotonin release and can reduce post-seizure respiratory arrest in mouse models. But this has not been studied in humans at this point. Getting back to fenfluramine, fenfluramine has been studied in Dravet syndrome for several years now, and it's been FDA approved for about 1 year. So in the patients who were in the Dravet syndrome trials for fenfluramine, they've been able to extrapolate the rate of mortality in patients who have been on fenfluramine versus historical controls. And in their study, the historical controls had a 15.8, their all-cause mortality, or they had 15.8 deaths per 1,000 person years in this historical control, compared to their patients on fenfluramine, where the rate was 1.7. Of those all-cause mortality, 9.3 of those were from SUDEP, which again was decreased down to 1.7 with fenfluramine, suggesting that there may be something to the serotonergic system, especially in Dravet syndrome. However, that also gets complicated by the fact that patients with Dravet syndrome on fenfluramine tend to have fewer seizures as well. So I'm talking about seizure monitoring devices, and I want to emphasize that these are not endorsements. I have no skin in any of this game, and none of these have been proven to prevent SUDEP. So there's only one device that's commercially available that has been FDA approved, and that has been approved for seizure detection, but it has not been approved for preventing SUDEP. Different companies have been marketing these seizure monitoring devices for a while now, and different things measure a combination of different movements. So either movements like tonic-clonic movements, they look at heart rate, temperature, or changes in the skin properties to try and detect when seizure is occurring. None of them actually use EEG, so none of them are looking at brain waves, and they may not be appropriate for all seizure types. There's only this one FDA-approved device, which some of you may be aware of, and this is the Embrace 2 watch by Empatica. It's been FDA approved for children over 6 years, and note it's only been FDA proven to detect convulsions that are greater than 20 seconds. And here's a picture of it. There's a bunch of other non-FDA approved devices out there, which we have very limited or no data on. So these would be things like anti-suffocation pillows, other seizure detectors that go under the mattress or on the mattress. There's other smartwatch devices, and then video monitoring devices that I'll get to a couple of them as well. And importantly, when talking about these with your doctor, these devices are not meant to replace seizure safety and precautions. So the Empatica Embrace 2 watch, important considerations. It can have quite a few false alerts. So in one reported study on it, there was a false alarm rate of about 0.2 per day. So those are events that are not seizures. And for some people that may create some false sense of anxiety. The device may miss seizures. They're not 100%. You have to be wearing it. So if you or your child is not actually wearing the device, then certainly it's not going to capture anything. But the sensitivity for capturing seizures is pretty good. In one study, it was about 95%. But again, that's only for convulsive seizures, and patients who have focal seizures or absent seizures, it's unlikely to detect them, or it's much less likely to detect them. Again, this device has not been proven to reduce the risk of SUDEP. Important considerations for technical aspects, it's got to be within 15 to 30 minutes of a 15 to 30 feet of a Bluetooth connected cellular telephone at all times. So when you're thinking about getting this for your 4-year-old, remember, you have to also consider, is your 4-year-old going to have a phone with them at all times? The device battery lasts 48 hours before it has to be recharged. So during that recharging period, then it's not on the patient and it won't be recording for seizures. The device itself is expensive. It's about $250, and that's not within reach for many of my patients. Your insurance company may not cover the cost of it, or they may help to cover the cost of the device, but then not the monthly subscription fee. So there's a monthly subscription fee depending on how many devices you want it to alert, and that may be anywhere from $10 to $45 that insurance doesn't cover at all. So it adds to your phone plan as well. And again, for many of my patients, that's not within reach, and it always bothers me about the health inequities of things like this. There is another FDA approved device out there, and I think someone was asking about other devices besides EEGs. And this one is actually being marketed towards neurologists, because this is actually looking at kind of home ambulatory EEG monitoring that's not an EEG on your head. So this device has FDA clearance for seizure detection, and it is placed on the biceps, and it has to be placed directly on the biceps at this very specific spot. It's found to detect muscle movement consistent with generalized tonic-clonic seizures based on an algorithm. So it records essentially the patient has to wear it home, it has to record several seizures, and then the team at SPIAC will actually create an individualized algorithm for that patient. And then you can continue recording for several months at a time. In addition, it sends the information to this monitor, which will send the data to a phone. So it can be potentially a seizure alert device, but it will also collect the data so that it can inform the neurologist about the number of seizures the patient is having. The sensitivity of this is anywhere from 76 to 100%. They claim that the 100% was only if it was being placed appropriately. So if the device was not worn directly on the arm where it was supposed to be, then it was not as sensitive. However, it did have some false alarm rate of anywhere from 2.5 to 1.4 false alarms per day. Right now, this is insanely expensive, $4,500 a month. But like I said, I think they are marketing it to replace an ambulatory EEG that can be worn for several months at a time, rather than our typical ambulatory EEGs that are being worn for 24 to 48 hours. This is something that I didn't know existed, but this is a company called an Epi Night Nurse, and this is actually an international company where there's video nurse monitoring of the patient at night. So this is a monthly service fee. It's pretty expensive, anywhere between $400 and $500 for 8 hours of monitoring per night. But you can create custom alerts so that there's a person on the other end of the camera who is monitoring, and if they see anything abnormal, then they can alert the caregiver. They can also alert the caregiver if the patient's awake when they should not be awake, or if their face is covered by their covers or their stuffies or things like that, other safety concerns that they may have. This, of course, we don't have any performance data available. And there's a relatively high cost of this, but some patients may find this useful. Video monitoring devices. I know one that several of my patients have talked about is the SAMI monitoring device. We have zero data on the performance of the SAMI monitoring device. It's a little bit of a high-tech baby monitor. The bonus is that it's a one-time cost. It's still relatively expensive at $400, that it's not cheap at all. But there's no subscription to it compared to some of the other services. This comes with an app, and the app is supposed to be able to look for abnormal movements and alert the caregiver if there are abnormal movements. But again, we don't have any performance data, so I'm not sure on the number of false alarms one might get or how good it actually is at detecting seizures. And then one that I had other patients ask about is something called the Inspire Watch or Inspire program. It's actually an app that works on multiple smartwatch platforms, including Samsung watches and Apple watches, which many patients already have. So this is actually just a monthly subscription, but it can be anywhere from $15 to $50 per month, depending on how many other devices you want it to alert. The sensitivity data on this is not great. So some studies found it at only 31% of being able to pick up a seizure 31% of the time, and it may be up to 92%. Again, that may be, relate to how accurate or how well a patient is wearing their watch. And it's really unclear how many false alerts you get if you're going to create too much anxiety by having many false alarms rather than picking up accurate seizure control or accurate seizure detection. So again, I'm not endorsing any of these devices because none of them have been proven to reduce the risk of SUDEP, but some patients and families may find them useful. Lots of places to learn more about SUDEP and SUDEP detection devices. The Danny Did Foundation is one that Renee had mentioned, and they're a wonderful foundation. This is Danny. Danny died of SUDEP at 4 years old in 2010. And his family was actually based out of Chicago. They started a foundation with the goal of preventing SUDEP. And on their website, they have kind of reviews of each of the devices, and they also have some grant support for patients to potentially obtain devices as well. In addition, I wanted to mention that there's a SUDEP registry. So SUDEP is something that is really difficult to study for all the reasons I mentioned before. And this is an organization that works with families, physicians, and medical examiners in cases of SUDEP with a goal of helping to gather more data and help us understand SUDEP and how we can prevent it. So my take-home points is that the mechanisms of SUDEP are still really unclear. So I probably left you all with more questions than answers, and it's likely multifactorial, involving other abnormalities, including cardiac, respiratory, brainstem, and neurotransmitter dysfunction. But what do we know about how we prevent SUDEP? Seizure control is the #1 thing that we can do to prevent SUDEP. Unfortunately, I know this is not something every patient can control, but if a patient is continuing to have frequent seizures, then we as neurologists should be continuing to help to find ways to prevent them, whether that be through medications, devices, or surgery. In addition, from a patient standpoint, taking your medications as prescribed and avoiding your seizure triggers, especially things like alcohol and sleep deprivation, may be helpful as well. And then if medications aren't sufficient, discussing neuromodulation or surgery if appropriate. Nocturnal supervision, we know, can decrease the risk of SUDEP, but it may not be possible for every independent adult. And then the question of cardiac evaluations in those potential high-risk cases. And with that, I'm happy to take any questions.
Great, thank you so much. What a great comprehensive, intro into what we're learning and even the things we don't know yet, but are hoping to learn. And Thank you for doing that with such sensitivity to the topic and providing such crucial information. Thank you. We do have some questions in the Q&A that I would love to be able to share with Dr. Ziobro. So here's one. If you have epilepsy and sleep apnea, are you at increased risk for SUDEP?
Oh, I don't know any of the data on that. Again, I'm not an adult epileptologist, but my suspicion would be yes, because both of those things would put you at independent risk factors. In addition, sleep apnea can also increase some of those cardiac risk factors as well. So, sleep apnea puts additional strain on the heart and can lead to some of the similar concerns that we see with epilepsy as well. So certainly I would encourage you to talk with your neurologist in addition to potentially, sleep specialist as well, to make sure you're controlling as many of those modifiable risk factors as possible.
Yeah, and I would say to everyone else too, if this brought up questions for you, I would really encourage you to bring those to your doctor, in part because, yeah, there are so many multifactorial pieces to this, and it's good to, make sure you're not just getting the information on the internet, but connecting with your doctor directly. So thank you.
Yeah, and on that point, I know we as physicians are not great at talking about SUDEP, and we have studies saying that we don't talk about SUDEP as much as our patients would like us to, because it's something that's on every patient's mind. So please bring up SUDEP with your doctor so that you get answers from your reputable sources.
Yeah, I think that's great. Someone has asked, I hear of parents using a pulse ox during the night to be alerted in a change of oxygen levels, which might act as an alert for a child's seizure. At what point might there be added concern for SUDEP, and what might a parent do to prevent SUDEP?
Yeah, so we know that also prone positioning, so patients who end up on their stomach during a seizure, or if they're sleeping on their stomach when they have a seizure, may increase the risk of suffocation during a seizure. So a pulse ox may potentially alert a parent to a decreased oxygenation. So the goal of some of the monitoring devices would be that a patient can alert a parent or a caregiver so that they can go and make sure that the patient is breathing appropriately and that their airway is not being blocked after having a seizure. There, again, is not recommendations for pulse ox amongst consensus recommendations in pediatric epilepsy. The biggest recommendation we can have is to have some sort of monitoring device in the patient's room, and typically that is an audio baby monitor, partly because we know that is attainable for most patients to be able to have a baby monitor in the room. But there is concern from a lot of my colleagues that things like pulse oxes and even some of these seizure monitoring devices cause a lot more anxiety because they do have so many false alarms. So amongst all my patients, I do recommend having, at least my pediatric patients, I recommend having a baby monitor in the room. But I think it's really up to the patients and the family if they want to pursue any of these other monitoring devices with the knowledge that they don't have data to support that they prevent SUDEP.
Thank you for that. When a medical examiner finds a case of SUDEP, is there a standard set of information about risk factors that is gathered, like genetic panels, microscopic analysis of the heart and brain, and does this help the family know what the cause of death was and possible familial risk factors?
Yeah, this is really hard and really complicated. So I will start by saying that most medical examiners don't know about the SUDEP registry. So what I would encourage is that in cases of SUDEP, that the medical examiner and the patient's physician and family, if they're interested in contributing to the SUDEP registry, that they get in contact with them, because they would go through with the medical examiner about the standard tests that should be performed in looking for cases of SUDEP. Medical examiners have kind of a standard set of things that they do, which doesn't necessarily involve genetic testing, right? So it may be things like they will always look at the heart for pathology, they will always look at the brain for pathology on a standard autopsy. In addition, again, when somebody passes, though, it is often the family's prerogative if they want an autopsy performed or not. And that's a very sensitive topic that is really specific to each family if it's something that they feel comfortable with or not. So there are cases where autopsies are not done and we don't have that additional data to say one way or another. That doesn't mean that patient couldn't be part of the SUDEP registry, even if we don't have all of the medical data. If the family's still, interested a year later in having that patient in the SUDEP registry, they can still gather some of their previous medical history and things like their EMU records, so that we can help to get a better picture of what may have led to SUDEP.
Thank you. How can you check your oxygen saturation? Is that something you would recommend?
Typically, no. So pulse ox monitors are notoriously not always accurate. So if you don't get a good pulse ox monitoring, like if the device is not on appropriately, which it often will slip off and not be on appropriately, you're going to get a false reading. So I don't typically recommend pulse ox monitors for my patients.
Thanks. You mentioned like false alarms and how that can create anxiety, and of course that can create more stress, which can create more seizures, and it certainly can also create more stress in caregivers as well. But I guess, you know, as you've given this talk today, and I realize that may raise questions, and it's like, you know, that's the biggest fear probably for someone with epilepsy or a parent. Like, just what advice would you give toward those anxieties?
Yeah. I wish I had a way to get rid of the anxiety, but it's real anxiety because there is a real risk, right? And I hope that I at least give the tools to try and prevent SUDEP, which right now we know that's trying to get the best seizure control possible. So continuing to work with your doctor if you're continuing to have seizures, and continuing to try and modify some of those risk factors, like taking medications on time, or moving towards the implantable devices or surgery if you're a candidate for it. So that's kind of the number one thing I can say to alleviate those risks. But I also still want to take home the point that even though SUDEP is a real thing, it's still very low risk, right? So 1 in 1,000 patients is not a super high number of patients who die of SUDEP, but so for most patients, it's not going to be something that affects them. However, I understand the anxieties from it.
Yeah, thank you. This is a really specific question, and it's not one I know about, but have things like Wolff-Parkinson-White syndrome or PACs or PVCs been associated with epilepsy?
So not specifically that I know of. So things like Burghardt syndrome, though, which is another kind of cardiac arrhythmia, it's related to an SCN5A mutation, has been associated with some patients with epilepsy. It's more commonly seen that patients with Burghardt syndrome have seizure, or sorry, have heart arrhythmias, but there have been some patients who have both seizures and heart arrhythmias. Again, kind of getting to the fact that some of those sodium channel genes can be really common. As far as PACs and PVCs, it somewhat depends on the underlying causes, right? So PVCs are really common amongst a lot of people, myself included. If I have too much caffeine, I have a lot of PVCs. I don't know of any literature that associates it with epilepsy.
Okay, thank you for that. Thank you for this time. Thank you for really addressing this. And like you said, so often people go years without even hearing about SUDEP and feel really, really concerned about that. And so thank you for approaching this topic with such depth and sensitivity and information. That's what we need. So we thank you. And if you'd like to thank Dr. Ziobro, you can put that in the comments as well. And we're going to make a transition to our last session for the day. Thank you, Dr. Ziobro.
Thanks so much, Renee. And thanks everyone for listening. And thanks most to the patients who've contributed to research.
Yes, thanks. Well, my friends, it is time for our last session of the day, and I'm really excited about this one. It is entitled Learning from the Best, Being an Advocate and Being Heard. This title comes from the 2022 Challenge of the Year at the Epilepsy Foundation of Michigan. For many of you, this is the first time you're going to hear what this challenge is. It is Building Advocates, Being Heard. And we want to encourage everybody in our epilepsy community to get involved in advocacy this year. And there are so many ways to do it. So today we're going to learn from 3 panelists who are going to encourage us in doing just that. And they're going to spotlight some of the projects they've been involved in and also share what it feels like to find your voice and passion in epilepsy community. And as we think about this, of course, we've heard a lot of medical innovations today, but we also want to hear how is our community being innovative? And I'm really curious for everyone listening along, what is going on inside of you as you have a new idea today, a new possibility today? What are you drawn to? So with that in mind, I want to introduce our panelists. We have Danielle Perdue, the organizer of the New Hope Epilepsy Support Group, Matthew Summerfield, who has been involved in TEDx and an annual hockey match to raise awareness about epilepsy, and Janiyah Roberts-Clay, who is going to talk to us about what it feels like to find our voice and she'll encourage us all to get involved in advocacy. So we welcome you. Welcome to our panelists. I'm going to get those videos on in a moment. While we do that, I want to just tell you a bit about what the challenge of the year is at the Epilepsy Foundation of Michigan. We choose a challenge of the year every single year to try to really move the needle on something that's big, something that is really connected to the epilepsy community, and to help do that together. So I'm really excited to welcome our panelists. Okay, so I am wondering, we're going to delve more into your work in a moment, but I would love to invite each one of you to introduce yourself briefly. And how would you define advocacy? What is it? And Danielle, could we start with you?
Sure. I just want to say that I'm really happy to be here. Really, really happy to be here. My name is Danielle Perdue. I have 2 children, and I have a husband, and I have a dog. Her name's Luna. Also, I live in Grand Rapids, Michigan, and I have received my bachelor's and master's in social work, and also I have a teaching degree. And I'm the founder of New Hope Epilepsy Support Group. For me, advocacy. Advocacy is standing up for a similar cause. It also is standing up for yourself and or being heard. Advocacy is also going above and beyond.
Love that. Thank you so much. And Matthew, would you introduce yourself, and what is advocacy? How would you define that?
Absolutely. Thank you for having me here. It's always a pleasure working with you guys. I'm Matthew Summerfield. I'm 22. I'm a senior at Hope College. I study neuroscience, chemistry, and psychology. I have a fiance, and I'm going to study neuroscience for my PhD in the fall, primarily looking at epilepsy. And I have idiopathic generalized epilepsy as well. And I would define advocacy as going beyond helping yourself because you're helping the community, not just in the actions you do, but in the emotions you give and the memories and the information you spread by creating the community, specifically giving to the epilepsy community.
I love that. Thank you. And it looks like we're missing Janiyah, so we're trying to reach out to her. I think there might be a technical issue on her end, but I will say that she is a person who was diagnosed with epilepsy about a year ago, and has really gotten passionate and is excited about getting involved. So I hope that we'll be able to get her on the screen too. But let's go ahead, and I would love to delve in a bit more. And I was wondering if each one of you could tell us a little bit about your journey with epilepsy, and then how did your experiences lead you to a desire to be an advocate? And Matthew, we can start with you this time.
Yeah, so definitely experience is where it all starts. I was diagnosed at 11, and I didn't really have anywhere to go with like any directions or advice to give other than like keep it a secret, the usual non-supportive answers from physicians. And so we did the exact opposite, and we reached out to the epilepsy community, and we're like, hey, how do we live with this? How do I grow up knowing what to do? And you guys helped, obviously. And one of the ways you helped was you said, well, you can start your own group at the Midland Stroll in the summer. And so we started Matthew's Mob, and as our own little like group, and slowly but surely it grew and grew every year with people. And as I got older, I realized that it's more important than just having that 1 4-hour period in May to talk about epilepsy. And I realized that, well, I'm going to have epilepsy forever. I might as well be an advocate forever. Everywhere I go, I'm going to be an advocate. because you never know who you're going to run into that has epilepsy and is more shy about their life, or they don't know what epilepsy is and they're really curious and they're waiting for that one person that just has a wealth of knowledge to share. And so I figured I might as well be that person, right?
Yeah, it's really, really great. Yeah, and Danielle, how about you? Like, would you just tell us a bit about your own epilepsy journey, and then how did that lead to you being an advocate?
Well, first off, I must say that definitely my journey with epilepsy has been quite a different journey, because we all have our own journeys. When I was diagnosed with having seizures when I was of the age of 14, and for me, the way when that was around high school, and I must say that I then became a little bit like, I was scared about epilepsy, and I was shamed with epilepsy. And I want to say, and I want to be real to you, that some of the times after I had my seizures, I would go in my room and I would start crying, because that was my way of coping with epilepsy. And there was at a time also when I had 2 brain surgeries. One was very quite easy to deal with, and that was a VNS surgery. And another one was a little bit tougher. And I thought I was going to be out of the hospital probably like 2 weeks. And then I was in the hospital for 1 month. And then I had to recover. And then I found myself having a lot of, going to see a lot of speech therapists quite often. That became a thing. And I kind of had to push myself up, and I kind of had to grow. And then moving forward, when I got my bachelor's and master's, I mean, during all this time, all my family and my friends were pushing me forward to stay strong. And I found out about you guys, about the Epilepsy Foundation, when I came to Grand Rapids. And I was alone. It was just me. I moved to a new town, and I was alone. And I went to some meetings. I started going to these meetings, and it became a thing. A lot of the people that I met, it became stronger and stronger. And then I'm like, hey, I want people to stick together with, and grow with everything. And that's why back in 2010-ish is when the epilepsy, New Hope Epilepsy support group started.
Yeah, and speaking of that, I wonder if you would just tell us more about how that came to be. What sort of things are you doing together? What is the New Hope Epilepsy Support Group, and what has it felt like to do it?
Number one, it has felt amazing in order to do it, because every single time when somebody comes and join us, either online, either on Zoom, or either in person sometimes, it's amazing. It's all started out, what the New Hope Epilepsy Support Group is basically, we started meeting we first started meeting in a church, and then we started meeting at coffee shops. And it just kind of happened, and I didn't know what was going to happen. And more and more people ended up showing up. And for me, the goal was, if we could just get another person attend one of these meetings, then my heart would be so warmed. And not only that, but like for me, that through having these seizures, I could, in a sense, like I felt a sense of being so close with everybody. And so we do a lot of that. We do a lot of that work. And then also we have, we just got donated some money to our group, which I am so happy for because now we're able to get more resources for our group. And also through you, that's when I found out really I could dive more, Renee, about like into the more into like everybody like all over the place. And now there's just a lot of people and it warms my heart.
It warms my heart too, because what's really great is we have, for anyone here, we have a support group that we do at the Epilepsy Foundation of Michigan for adults with epilepsy every Thursday, 1 to 2:30 p.m. And this same group, we got invited to come to New Hope once a month. And so now that group is just loving also coming to the New Hope Epilepsy Support Group. So it's meant a lot to them, I know, and I'm so glad you're doing it. It's great. That's awesome. Matthew, would you tell us how the annual hockey game came to be and what was that like this year? And then I also know you had the occasion to give a TED Talk this year when TEDx came to Hope College. So what did you choose to address in that talk, and how did it feel to get involved in this way?
Yeah. So the hockey game, listen, I grew up playing all kinds of sports, but I began playing hockey at like age 6 or 7. And that's, you know, the best activity I've ever participated in my life so far. And it was something that, you know, allowed me to just be another kid. It allowed me to be normal, right? I didn't have to worry about, well, I mean, I worried about having a seizure while playing, but it never happened, right? It allowed me to just bond with other people and, you know, be normal, be normal, right? And after a couple of years of doing the Summer School for Epilepsy and doing some fundraising, I was like, man, what if we do like a benefit game? What if we do a benefit game? That'd be really cool. I'll make the jerseys. They'll be super cool. You can buy the jerseys if you want. You can do, we'll have like a bake sale. We'll do 50-50. We'll do chocolate puck. We'll do all the stuff, and it'll go to epilepsy, right? Because if I'm playing in the game, it gives more people incentive to come, right? And so that apparently became true. And ever since then, we've every year we've been trying to do it. I think last year we didn't do it because of COVID, and there wasn't really a regular hockey season. But essentially, what it was my high school, who has a team that's composed of several different high schools in the mid-Michigan area, and a rival high school. And you know, we agreed. I usually knew a couple of guys that were on the opposing team, and they'd talk to their coach, and we'd set it up. We'd get the jerseys, and we'd make T-shirts for the game. And if you sold T-shirts and bought a T-shirt, that T-shirt was your ticket for the game. And it ended up being a success every year. So we kept pushing it forward. And this past year, I went back home to watch the game. And I even don't know anybody that plays because it's been 4 years since I graduated high school. So a whole rotation of students have come and gone. And even though no one knew me, they still showed up for the game. They still supported. They still donated. Companies made donations. You know, it's excellent to see that it's still able to go on, even though I'm not there. And that's proof in the pudding that, well, something that got started kind of got attached. And I'm glad that it's able to still go. And then additionally this year, I had the honor of giving a TED Talk. It was one of those things where it's a once in a lifetime opportunity. And, you know, I felt that I needed to say something. And so what do you do at a TED Talk? You talk, you say things. And so this was the second year my college hosted the event. And this year's topic, they have 10 speakers, and the topic was every single day, like just every single day. And so we had a wide variety of speakers, and I was selected to be one of them after some auditions, and I wanted to talk about what every single day living with epilepsy was like. It's simple, because not a lot of people know what I go through every day or what someone else with epilepsy goes through every day, because those two different days look very different. And so I'm writing my speech, I'm getting it down, and I realize I want to do some more than just talking about my story. And so I talk about how to make your community epilepsy safe, which is the title officially of my talk. And so I talk about that. I talk about my experience. I talk about what I view has been going wrong at the approach to handling epilepsy at a social level, as far as implementation of seizure first aid, social norms, expectations. Obviously, stigma is a huge thing. So I address all of these in my about 14, 15 minute long talk. Currently, it's in the waiting phase. So it's like when you order a package, like I got the email that says package has been sent. Now I'm just waiting for it to actually arrive. It will be available on the interwebs on YouTube. Once I know, right, I'll send word by email and Facebook and carrier pigeon and whatnot. So that everybody can watch it and share it, and hopefully what I said wasn't a bunch of nonsense and someone out there agrees.
And I got to see it live, not in person, but during, live streaming, and it was a very powerful moment. And I just want to applaud both of you, but everyone else listening, like, this is innovation. These things didn't exist before. And so what is it in each of you, everyone listening, that doesn't quite exist yet, but something that you see and something you have a skill to participate in or provide? I love thinking about those questions. So for both of you, I mean, what would you say if someone's newly diagnosed and maybe new or new to getting involved in advocacy? How would you encourage them to get started? What's a first step? Danielle, what's a first step for people?
Yeah, I think the very first step is, number one, it may come at a different time. It does come at a different time for everybody, but accepting the fact that you actually do have seizures. But not only that, but also having family and friends to support you and to help you. And then also another great big one would be to find your resources. Find your resources and find out where they are coming from, because all those things are going to help you a lot. Like the Epilepsy Foundation, and figure them out and learn about them. If you don't do it, if you don't actually do it, nothing's going to happen. You have to just try, and it may be something small, but then you actually realize that it's gonna happen and stuff. You'll find better feedback. Yeah,
even these small moments and actions, they can add to a big impact. And Matthew, I need to announce that there's a carrier pigeon in the chat named Nicole Fitzpatrick, who just told us that it is live and put the link there. So thanks, Nicole. So yeah.
Well, you might know something I don't know. But,
but Matthew, what would be your advice? First steps for people to take if they haven't gotten all the way involved, or maybe they have that idea but they don't know how to get started.
Yeah, I mean, Danielle provided a lot of excellent answers, and when I was thinking of this, obviously coming to terms with having epilepsy is a big one, but if you want to be an advocate and you don't have epilepsy and you're the caregiver or you're a friend of someone with epilepsy, you have to create that support team. You got to be in that support team, and being, you know, being there for someone else is vital to building any sense of trust and any sense of community with you, and I mean even just your local community, and then just having it in just an unrelenting sense of selflessness. Like that's just like the best thing to be is selfless. And in this sense, for advocacy, you're just, it's almost like information dump. Like you just kind of like here's stats, here's what to do in the event of a seizure, here's famous people with seizures. Famous people can have seizures too. Famous people can have epilepsy too. Old people can have young people. Here's all the different types of epilepsy. It is overwhelming because I've definitely done that to a lot of people, and obviously they have follow-up questions. It's all fine, but it's like I need to show you that there is more than just this term epilepsy. There's more to it, and I mean to get involved and to like how do I take my first step at being an advocate? You have to be well informed. Like you got to be well informed because you're going to inform people, and so definitely do make sure you do your research. And I mean, I kind of always carry around some sort of pamphlet or handout or something just in case. You never know. I just have like a small folder of them in my backpack, and just to be ready and like, you know, I know people forget things, so here's a physical copy of what I just said. Because you never know, they might retain it after a while.
That's true. And the relational connection as well. Like I just got some new like official cards with my name and everything. And I the other day I was like, oh, I better put some of those in my purse because you never know when you're out with someone. And I just ended up in a place, and I met someone I've never met before. I said where I work, and she said, oh, my mom has epilepsy. And it's like, oh yeah, give us a call. You know, that relational work, that's part of it too. And we all can do that because we all have a story and we all have connections. Also, we know that people can find a deeper sense of identity and belonging when they take action in a shared direction. So I'm wondering if that's felt true for you, and how has that impacted how you think about yourself as a person with epilepsy? And Matthew, I'm wondering if you'll start this time.
So thinking of myself as a person with epilepsy, it took a while for me to, I guess, understand what it meant to have epilepsy. I just figured it was just something. Yeah, I don't know. It was just something. It was something I now have to take medication every single day for. And every now and then I had a seizure, and that was it. And, you know, keep taking medication, keep having a seizure. And that was just going to be my life on repeat for a while. And then at one point, obviously not too long after just the repeats of seizures and medications, I kind of got annoyed with it. And I'm like, okay, I need to figure out how do I become greater than something that is invisible that still controls my life? Like, how do you do that? And it's simple. You do it every single day by being the best person you can possibly be. And that's obviously way easier than said. And there's multiple ways of doing it, but you know, you go to your job, or you go to school just like anyone else, and you perform your task just like anyone else. But there's a sense that you're like, I'm still doing this, whatever it is, as someone with epilepsy. I'm still doing, you know, simple things like going to Myers and getting groceries. I'm still doing that, but there's a chance that in, you know, the cereal aisle, my favorite aisle, I would have a seizure. What do I do? What do I do in this event? And you know, I think about things like that, and that's why I do advocacy stuff. Because if you have a more informed population, you have a higher chance that someone stumbles upon you when you do have a seizure, that they do know how to perform seizure first aid. or they do know that like, oh, that is a seizure. Because this started really early in my seizure experiences. Was my first seizures. I had a series of them at my house back in 2011. And the emergency personnel didn't think I was having seizures. They thought my parents drugged me, which was very upsetting because it's not like my parents do that, because that's child abuse. But yeah, and so I'm like, well, if you're a paramedic or an EMT, shouldn't you almost know everything? Shouldn't you know what a seizure looks like versus, an overdose? Just 11-year-old thoughts. And so that sense of just trying to inform anyone at any moment has been instilled with me since the beginning. It has stuck with me.
Yeah. And I mean, that's true for everyone here. I think like growing up with epilepsy, I felt that stigma really heavily, and I really associated that. Like, well, Danielle, you said I felt ashamed, and I did too. And I think that there was some part of me that thought, oh, if people know this about me, they're going to associate me with epilepsy, like this really bad thing. But now at this stage of my life, it's actually the complete opposite. People associate epilepsy with me because they know someone. They know someone who has had this experience and knows this and does this work. And so it matters to them. It's humanizing it. It's not just this like boogeyman, amorphous, shame-filled thing. It's humanized with all of us. So the more people can come to know that, that increases the knowledge, and it also increases the care. Danielle, like what would you say? What has it felt like to do work also together with people, right? To be doing it in the same direction, and how has that impacted how you think of yourself as a person?
Oh my goodness. To find that when working with other people, or just being with other people, and to know that they have seizures is it like, I've used this word like several times, like throughout the day. It does warm my heart. It does warm my heart because everybody is working together, and they have seizures, and just learning about all these different seizures and thinking about them, and how are you going to deal with them? What are you going to do? There's so many different possibilities when you hear about so many different people having, and no seizure is the same. So if no seizure is the same and you're finding out gobs and gobs of information, it's awesome. And another thing that I just want to address is that people don't really understand this. Some people anyways, but you got to make sure that like it doesn't define who you are. Like you can walk in a store and like Matthew was talking about, like it just doesn't define who you are. And you have to lift your spirit up, and you have to keep on going strong, because just seizures don't define who you are. And working together with more people and understanding who they are and getting closer and closer to them, and everybody has seizures. It's awesome. It's amazing. And I wouldn't give it up in a heartbeat.
Yeah. Who are some of the circles of people, either within the epilepsy community or beyond it, who have shaped you in this work that you do? And what are some of the best lessons you've learned, and how do you take that into your advocacy? And Danielle, we can start with you this time.
There has been a lot of people that I know of, and I can definitely say that the way and how they have shaped me is definitely one big thing is challenging me in multiple ways in order like to put myself out there and actually do something that maybe sometimes I would not do, you know, challenging me, redirecting me, and just being there for me in so many different ways. And sometimes it's just like, that's what we need. That's just what we need. And if we had that every single day, then man, I would definitely be a happy camper.
Love that. And Matthew, who are some of the people who've most impacted you in this work, and what are some of the lessons you've taken from them? Oh, I think we lost your sound. You're muted.
There we go. Double clicked it. Definitely my mom and dad. They are obviously the people responsible for literally making me, like for my upbringing and everything. And even I'll give credit to my older brother who also had epilepsy, because they're with me through it all. So, they're the ones that obviously provide me the most support. Same thing with the rest of my family, my fiance. I'm pointing over there because she's.
Yeah, I was like, oh, she must be there.
Yeah. You know, like my teammates, my friends, a lot of people that, you know, they see me every day, and then when I do like an event or start something that's like pushing toward advocacy, or make like a post or even just make a comment about living with epilepsy. You know, sometimes it's the people that don't see someone with epilepsy, and when you get introduced the first time, or you make an offhand comment like, even though my medication makes me tired, I still do X, Y, and Z every day, or something like that. And some of my friends they'll take notice, and they're like, I can't believe that you still do this. I'm like, yeah, of course, because if I do something now that hopefully inspires the 11-year-old me, or the 11-year-old me that's out there right now, my work's done.
Yes, I love
And that's what I aim to do, right? It's
Yeah.
like I hope to inspire, or not just inspire, but motivate another individual, young, old, who has or doesn't have epilepsy, to join the advocacy, right?
Yeah,
We can always have more people.
Right. Well, first of all, you are doing it, and you will do it, and it's really lovely. So yeah, I celebrate that. Okay.
Yeah. Can I say something really quick? This has just been on my mind. I gotta say, I gotta send a special shout out to my mother. Yesterday it was her birthday. and also probably I would never even really kind of know what advocacy was if it wasn't for her. And my family and friends that have been there for me definitely have been inspiring me throughout the ways, because it definitely isn't easy. It's hard. And those are your support team that lifts you up. So I just want to say that.
Yeah, I mean, I'm so glad you did, and happy birthday to her. And also, that's so true. I mean, I'm going to give a shout out to my best mentor, who's really been like a parent to me in a lot of ways, who was really the first person I kind of poured out this epilepsy story to. And just today I was, texting him and saying like, okay, I'm hosting this conference today. And I never thought I would be doing this work, but it is the people who really encourage you and are good mirrors to you too, like really helping see that you have all the worth and value and all the skills, to get involved in some aspect of what is collective. And I really, it's beautiful. So I'm with you on that. Now, this is a big one. I really would love to hear from both of you. What are some of the biggest needs for change in the epilepsy community right now? There are obviously lots of barriers in understanding, in care, in systems, and maybe the overall experience of living with epilepsy, at least aspects of it. So where and how should we be moving the needle toward collective change? Maybe in innovative ways. Yeah, Matthew, how about you?
Yeah, I can think of a couple right off the bat. I'd like to point out, I think it was when I was 17 is when I started seeing an adult neurologist, Dr. Burdette, my favorite doctor in the world. And it wasn't until then that I was informed about SUDEP. My first doctor didn't tell me about it. And I was, that's kind of a big, I'd say relatively big thing to talk about, especially for a family that's new to epilepsy. So just increasing the information initially and allow that, listen, here's the whole world. There's a whole world of epilepsy, and I'm here for help. And then directing to the Epilepsy Foundation for additional help, right? And then following that, getting more into, certain avenues of life. There was parts and moments in high school, obviously, where I did instruct my teachers of how to take care of me in the event of a seizure. That was pretty standard though. And the same thing happens in college. And I would kind of expect professional institutions to be better equipped to handle that. In one circumstance, I went to the disability services at my college, and because you have to recheck after every semester to apply the same accommodations, and they just they opened up the meeting with me by saying, "So, is your epilepsy gone?" I'm like, "Yes, it's gone. It's just got up and left." I'm like, "No, it's not gone. It doesn't just leave."
Oh.
So there's, and I get it. There, maybe this is the first time they had to deal with a student that has epilepsy. I don't know what their experience is like, but had they had the information and more, I don't know, experienced with what epilepsy is like and how living with it is like, they probably wouldn't have asked such a stupid question. And that's, all this information, I keep saying more information is better, but some of it's a little bit relies on the individual with epilepsy. There's a small percentage that relies on us, that we need to be vocal about what we live through, because if we're not vocal about what we live through, no one knows about it. And I've had people that I went to school with a guy from kindergarten through the day we graduated, and on the day we graduated, he's like, "Hey, I have epilepsy." What? Why didn't you tell me earlier? He's like, I didn't want anybody to know. I'm like, okay, I get it. It's the personal opinion, but if you had a seizure and no one knew you had epilepsy, what if it led to a SUDEP event? What if? There's a lot of what ifs in this, and just being more informed is just the precautionary measure.
Yeah, thank you for that. Yeah, and you're right. I mean, we all get to decide how we talk about this, how we disclose, who we tell, how we tell. But I think there's something so empowering of being able to step forward and not feel like you're in the shadows, or that you have to be, right? And I thank you for doing that, and so many of you who have done that and are doing that. Danielle, what do you think some of the barriers are right now? Where do we need to collectively, all together, work on moving the needle for change?
Well, Matthew, you said a lot of this, but I can agree with you on everything that you said. One of the barriers that I find that within a lot of circumstances is basically there's so many people that don't know what epilepsy is, right? I mean, not everybody knows what epilepsy is. And it's just like people don't know about what epilepsy is. And then when it comes time, and when somebody is going through a seizure, whether it be a grandma seizure, whatever type of seizure, then how do you deal with it? Well, you definitely need to get the word out there, the word of wisdom, and it needs to be heard. I mean, and when I finally came out, it took me a while, a really long time, in order to grasp to the point that actually I had seizures. I had seizures myself, and actually, like said, it was going to be all right. It doesn't define who I am. But I can definitely tell that when I started doing that, there was a change. And not only that, but like people started listening, people started caring, and like people gotta just kind of, in a sense, like just grasp together and go for a certain change for a certain reason. There's a certain reason, and and you never know who has seizures. I mean, I'm finding every now and then, like probably like this month, I found like 5 people that I know like have seizures. That's only because I started talking about it. So I'm just like, you know what? Like, that's what we all need to do collectively.
And let people know how common this is. I mean, when I was a kid with epilepsy, and for those who may wonder, like my epilepsy has remitted at this point, but I had a really intense experience of it in childhood. And I can't imagine what it would have been like to know that how common this is. Like, we didn't have that stat back then, but now we do, to say 1 in 26 people will develop epilepsy at some point in their lives. Like, that is a lot. So yeah, I mean, and people are out there. And when you talk about it, Brianna Romines and I say, you just bring it up somewhere and someone goes, oh yeah, my aunt, or I have a friend, or I had epilepsy years ago, or you hear it all the time. Everybody knows someone with epilepsy, whether they know it or not. Everybody does. Another thing I would just add, when I think about the barriers and the larger challenges, the one, I mean, maybe not the one, there may be more than one, but a one thing I think about is like how to solve transportation needs. And I don't even know how to do it. I do not know how to do it. I will get calls sometimes from people. I think that they are wondering if we provide that service, and we're, serving a whole state, and we're like a staff of 9 people. We don't do that. So I usually tell them about paratransit in their county. Every county via the ADA, the Americans with Disabilities Act, is required to have paratransit, like door-to-door service. But what if you live in one county and you work in another county? Then that doesn't work for you. Like Uber and Lyft, I'm so glad that these rideshare opportunities are available in a way that they weren't before, but they're expensive, and they're expensive if you're going to use them regularly. And every county is so different and has such a patchwork of options and non-options. So I don't know how to solve that, but that's something that I think about. And if any of you are like, that's my thing, like that's where I know how to solve it, like get involved. We want that. And speaking of that, it's really important to find your best advocacy fit. Like we don't all have every single skill, but we each have skills and interests and passions and people we know and community contexts we're a part of. And how would you encourage people to discover those gifts inside themselves? Like, how do you find that? And Danielle, I want to ask you first.
Yes, I believe that I think I kind of hit on this a little bit earlier, but pretty much you got to try a lot of different things. I definitely know with the advocacy work that I have been doing, I look to see what wasn't going right and what wasn't helping our group. And then you kind of recognize it and you change it. And sometimes you just you just really need to have an open mind, I believe, within that. You can't turn yourself down and shut yourself down and think like it's not going to work for you. You got to keep on believing and you got to keep on trying. An example for this definitely would be when the whole COVID thing came around. And we started doing the Zooms. I started doing Zooms for many things. I can tell you I was scared galore Zoom. I didn't know how to operate it. I didn't know how to do anything. And that was my main thing. I'm like, okay, I gotta do the Zoom. But after a while, like learning from people, kind of learning and recognizing to see what is fit for you and what is not that fit for you, it gives you a challenge of hope, and it gives you a chance to finally realize what really does work and what doesn't work.
Oh, so good. So good. Matthew, how about you?
I mean, simple answer, trial and error. Is especially with finding activities or trying to plan an event that you like to do, like obviously for me, I did the hockey game. Simple. I like hockey. Everybody else should like hockey. Why not also throw an informational point about talking about epilepsy into it? Seemed pretty successful. But then there's other simple things like benefit dinners where you partner with a local restaurant. You do 10% of every bill will go to my charity. And I mean, for us, what we did was like we did it from like 4 to close or whatever, and me and my family were there, and we had like handouts and whatnot, and we talked to people that were eating. We're like, hey, do you have a second to talk about epilepsy, or would you like to learn more? And it just slowly grew and grew, and every year we've done since. And it's just one of those things. There's like, well, you had to try somewhere to try at a simple aspect or a simple event and see where it goes from there. Or I mean, for a lot of people, especially, I'm not the most artistic or best equipped to handle social media, but some people are, and some people are great at spreading information on social media and being relatively regular with their posts or their updates, and just making like a post or a video or recording or doing like a podcast and sharing that as a way to just do something, right? And those are all relatively helpful in equal ways.
Yeah, just trying something out. Yeah, absolutely. And then sometimes just telling some people what your idea is, and it doesn't mean that therefore we can't get involved in every single thing, but you begin to find the people who are also interested in doing that thing. And when you can pair yourselves and then become 3 and then become 5 and then become 15, it's amazing how that snowballs, and it leads to things you didn't even anticipate, which is really great. In advocacy work, we can sometimes face conflict. That involves inner conflicts inside ourselves. Could be conflicts with other community members, or definitely conflicts with people who don't understand epilepsy, or who may misunderstand or overassume, or all those kinds of things. And I'm just wondering if you face some of these in advocacy work, and then how did you address them? Matthew.
Yeah, there's been a handful of these throughout my time. I mean, obviously from my mentality is loud, aggressive, and just like, I just always have a chip on my shoulder. And so growing up, I was just open about my epilepsy, and that came with consequences of being bullied, which is, part of childhood, unfortunately, but no one told me this, so thanks. But I listen, it's whatever. I forgive the people that said things, did things. There's nothing they can do about it now other than, apologize to me if they can. And, it made me understand that not everybody understands things like I'm trying to understand it. And even going beyond just my regular life, going into, trying to get donations for the hockey game, or getting sponsors, stuff like that. There's been multiple times where I'll explain something, and they just say, well, you don't look sick. And I'm like, that's because it's in my brain. It's not, you can't see it. And but that's the biggest point, is like no one like okay, epilepsy, seizures, cool. But until you see that seizure, and I talk about this in my TED Talk, it takes seeing that seizure for people to freak out, because it's so violent and so aggressive that it leaves a lasting memory. And for a while that was something that harmed me. I had a seizure in class, and I was isolated for like a couple of weeks or a month, because people like that was not Matthew, that was a demon, right? But my close friends are like, so that's what happens to you? And I'm like, yep, that's what happens to me. And it's tough, but actually it was beneficial, because more people were, after a while, right, they're more willing to ask me about what living with epilepsy was like, and if what it was like to have a seizure. I'm like, that's not like I just pass out, I'll tell you. But it was a tough battle trying to like figure out like what people wanted to hear from me and what I should tell people in the, I guess, the conflict of addressing epilepsy and trying to be an advocate for something people can't see.
Yeah, and one of the things you just said that really struck me is how we simultaneously have people that are downplaying and underplaying. In fact, someone in the chat said saying you don't look sick is called gaslighting. I mean, it really can be. It can rise to that level even. And then the opposite of people being in such a panic, in such a reaction that they have no clue what to do in the moment. Like, and just how far apart those are, right? And so that sense of education and personalizing it is so important, so that both aspects of that are not happening in the same way. Thank you for uplifting that. Danielle, yeah, let's see. Yeah, have you faced any conflict, and then how did you deal with that?
Well, it all depends. Nowadays, I don't really think that I'm too much older, but I'm a little bit older. When I was younger, I would probably face it a little bit differently. I had a very loud voice and conflict for me was pretty much showing my really true colors and getting upset about it. I would say nowadays, the way that I deal with it is pretty much if something is said or whatever happens, whether it be at work, whether it be doing a Zoom meeting, or whether it be with friends, then you kind of gotta take a little bit, you kind of gotta tone it down. For me, I want to tone it down, and I just kind of gotta rethink about it for a little bit. And I just sit there or stand there and think about what that person actually is saying. Is it actually worth my time to really, really deal with what is being said to me? Or should I just save my soul and just walk away, in a sense? And also, like, just pretty much the main thing is keeping an open mind during this too, listening to the person instead of right away, just all of a sudden just saying something that you're going to regret. And if that person says something to you that is really bad, then maybe in the long run, they'll know what they did.
Yeah, thank you. There's so much wisdom in there. I think a lot of people can relate to that with conflicts that are epilepsy related or just other kinds of conflicts, right? And that's really great. I am so excited to ask you this last question. So advocacy is not typically something we do alone. It's something we do together. So to conclude this part of our session, and then we'll go to Q&A, if you were to cast a grand vision of what the Epilepsy Foundation of Michigan might look like as an advocacy community in 2022, what might that look like? Either of you can start this one.
Yeah, I I can definitely see, I have thought about this one. I have really thought about this one quite a lot. I would see a lot of new faces coming within the Epilepsy Foundation. A lot of people being opened to what is to come with them. You guys offer so many programs that people don't know about, and it's just like people need to know about this, need to know, like for the stroll. I mean, that's one, for instance, that is coming up. Well, kind of coming up, but it, you know, time goes by pretty fast. But anyways, so for the stroll, it's just like people participate in something, you know, here in Grand Rapids. If more people can participate within like the stroll, then that'd be amazing. And I would see just more people getting involved, participating, everything. Like I can see it being super huge in my own eyes. I can see kind of like, to me, that's how I would envision it. Like just a lot of like growth and a lot of people pushing forward, doing what they want to do for a certain cause, for a certain reason within the Epilepsy Foundation. It just would be so awesome.
Yeah, so good. Matthew, how about you?
Yeah, I 100% agree with growth as an answer. Number one answer is growth. I'd love to see more people at my favorite event is the summer stroll. Just because it's a fun time for everybody to get together and see, feel from different areas of wherever you're doing your stroll from, and bring your friends and family and coworkers and neighbors and whatnot. But I'd also like to see more participation in the groups. Obviously, being, you know, the young adults group, I'd like to see more young adults join that as they try to figure out what living with epilepsy means when they're 16, 17, or they're getting ready for college, or they're trying to balance a job and learn to, you know, handle the prescription on their own, or go to their doctor's appointment alone, or anything like that, where it's just a big transition. I'd like to see a lot more participation and a lot more people turning out for events like that.
That's exciting. Thank you for casting that vision, and just know that we are all collectively casting that vision. A few things that come to mind, you know, just organizationally at the Epilepsy Foundation, we can always think of the Epilepsy Foundation as an organization and a community, and it's always both. On the organizational level, which does reach into the community level, we're in a like 3 to 5 year strategic plan right now that is going to expand a lot of what we do and what's possible, and we're thrilled about that. When it comes to the wider community, get involved right where you are, because let's say you're one of those folks up in the Upper Peninsula or in the Upper Lower, like get involved there, you know, find the people there. We can expand our reach, but also like find your thing. I'm going to tell you, this is like a sort of a community formation philosophy I have that I think is really helpful. And I learned this from Adrienne Marie Brown, who is an activist, comes out of Detroit. It's written some amazing books. But she says, don't be a mile wide and an inch deep. Be an inch wide and a mile deep. You know, find your thing and go deep with it. You can't do all things. You can't. Otherwise, you're going to be a mile wide and an inch deep. Be all in on like one thing or a few things, so that you go so deep with it that you begin to build community around it, and you start to be connected to people who are doing the other pieces. And then it becomes this collective whole doing so much. And it's so, so exciting. I want to thank you for your perspectives. This has been tremendous. I can tell our chat is like on fire. Everybody's like fired up. I'm fired up too. And I'm so grateful for you both. So please, everyone, thank Danielle and Matthew in the chat. And we're going to go into a time of Q&A for 15 minutes. So please, if you have comments or questions that you'd like to add there, please put that in the Q&A feature. Yeah, we're really thrilled. So I want to start with this one because you were just talking about the strolls. So if someone has never gone to this, they're just saying like, hey, it's a great opportunity to invite our communities to learn more. What can we expect if we attend? What do they like? I know you've both done that. Mm-hmm.
So, I mean, I'll talk for a bit, and anything I miss, you can pick up. And I'll speak on the behalf of the Midland one because that's the one I attend. Mm-hmm. Okay, so there's multiple strolls throughout like May to August. The one I attend is in Midland, Michigan, because when I'm not at college, I primarily live in Saginaw, Michigan, because that's where I'm from. And so at these walks, there are multiple teams, essentially. My own team is Matthew's Mob, and we have matching shirts. And there's, you know, an assortment of other teams with creative shirts as well. And it's like team this, whatever that. It's just something to do with their first name. And you generate a bunch of people with your team, and you do a walk. And before they have a nice talk about epilepsy, there's food, there's beverages. And it's a way to communicate with other people that share the same experience as you. If you're someone with epilepsy, or if you're a caregiver, you talk to other caregivers. It's just a unique time to get together without being at like a conference where you're sitting and listening. You're walking around and talking, and usually it's kind of a nice day outside, depending on if you're in the May or if you're in like July.
Yeah, and also Shannon Wade, our education and outreach specialist, put in the chat the link to the strolls, and maybe we could put that there again, so you can see where they all are, and they are taking place from May through August, and we hope you'll get involved in one. It's great. It also greatly supports our larger vision of what we do. They are our biggest fundraisers of the year, and they're also such great opportunities to connect relationally. It's great. Well, Danielle, I got a question for you. And when is the next Zoom meeting for New Hope? And this person also gave you a shout out and says, you know how much you've made an impact on our lives? You have. And thank you. Even though we know we can do it, and can't wait for the next meeting. So do you have a date, or how could anybody get involved? Could we put?
Yes. My intent was to actually get my Zoom all squared away so I could put it in here today, but I didn't, because I am a mother, and I also work full-time overtime, and I try to find my soul within a little bit, but I will pop in for you okay.
Are you gonna do your email?
My email, yeah.
Excellent. Let me put that in the chat. Cool.
And then it is, I will tell you the date in a second. And Matthew, if you would love to come to be a host at our meeting, then I would really appreciate that.
Sometimes Danielle invites specific speakers.
That would be totally awesome.
Also, Danielle, make sure that you have it on the setting that says everyone, so that everybody sees it. I don't know if you put it in there yet.
Will do. Yep. Okay, awesome. There it is.
Cool.
Okay.
There it is. Oh, so good. Okay.
And then it is, I'll quickly tell you the date. I believe it's towards the end of the month. It's let's see, pop it up really quick. Let's see. It's the 25th.
Is that a Friday?
Yep, we've had it on Fridays, and so it's the 25th, and we normally have it like at 5:30. And I encourage you all to go to the call-ins through the Epilepsy Foundation and to figure out what works for you, to also come to ours too as well. And then I can tell you about more in Grand Rapids too, which there is, because through there's more. Yeah, it's interesting finding out about all these things, because a lot of the times, like, you don't really, like, if I would have knew about one of these when I was younger, then pretty much it would have been really, really, really dear to me. It would have been awesome. Totally awesome.
Yeah, and just want to let you all know, as you said, Danielle, you said come to one of the groups for the Epilepsy Foundation of Michigan. We have 5 Call and Connect groups. I'm going to quickly tell you when they are, and we can put this in the chat too, and you can find it on our website. But the adult meeting is Thursdays from 1 to 2:30 p.m. The older adult meeting is Wednesdays from 4 to 5 p.m. The young adult meeting is second and fourth Sundays, including tomorrow, if for any young adults out there, at 7. And our parents group is weekly on Tuesday nights from 8 to 9 p.m. And our teens group is on the third Thursday of the month from 5 to 6 p.m. So we're going to put that in the chat too, but just letting you know, we'd love to have you. So another question, what are the biggest challenges you face as an advocate? Biggest challenges?
I would definitely say, wait, say that one more time.
Yeah, what are the biggest challenges you face as an advocate?
One of the biggest challenges that I face as an advocate, definitely for me, it would be sometimes it would be staying strong. Sometimes I believe you're doing so much for other people. You're helping out other people. And then in the process of all that, you're doing so much, which kind of like, in a sense, it kind of like gets you down, because you're helping so many people, you're doing all this, you need to find relaxation. And sometimes it's hard to find relaxation. Where is the relaxation? Well, you got to make sure that you find that for yourself to boot your whole soul back up, to get in the game plan of stuff. I would say that's where it is for me.
Thank you. Matthew, how about you?
Yeah, sometimes if you're really going 100%, kind of run out of energy, and the smallest infractions can kind of set you off track, or if you're trying to do an event, plan an event or something like that, and in my case, I've had a seizure in the event of planning an event, and it kind of gets you down in the dumps, because you're like, why am I doing this? Why am I still doing this event or planning this event or whatever it may be, if I'm still going to have seizures? And I don't have an answer for that, other than you have to keep moving, because if you stay stationary, it's just only just going to get worse. And so that's probably the biggest challenge. Well, personally, is just still battling epilepsy while being an advocate. Kind of challenging in itself.
Yeah, thank you for that. And I'll just add, I think one of my biggest challenges is I want to do everything. So I feel like I can't, just being like, okay, or I'll maybe do too much. But I think what makes me excited at this chapter is how many people already have been doing so much and just want to get involved. And it's so exciting to be able to say, like, here's some opportunities, or here's someone else who wants to do this thing that's uncharted. This is innovation. This is community innovation. I want to finish with this question, because I just think it's so important. How would someone who hasn't shared their story with anyone other than direct family go about sharing their story? I don't post online often. What are some suggestions?
Yeah, that's a harder one, because I think it can be different. I think it can be different for everybody where they are at with their seizures. If where they are at the time is they actually want to share, then I would definitely encourage them to share. There's going to be many people along the way that are going to push you down and stomp on your little tail. And it's going to be very, very challenging to actually be heard and to tell your story. Somehow you gotta, by God's good grace, you gotta find your peace in your soul and start telling your story. Start telling your story to whoever you feel comfortable sharing your story to. Just start little bits and pieces, because it's not overnight. The world is going to change, but little by little, you can do that.
Yeah, absolutely. Matthew, yeah, any advice?
Yeah. If you're looking to, I guess, expand the number of people that know that you have epilepsy, and you're nervous, rightfully so, of being judged or looked down upon, stigmatized, I would recommend going and telling the people you spend the most time with. If you're in school, probably your classmates that you sit next to in your class, or that you spend a lot of time around. In the event you do have a seizure around them, they should know what to do and that you do have seizures. If you're on a team or if you are employed, I'd let and it's hard to say, like, let your teammates and your coach know, or let your coworkers and your manager know, just for your own health, right? But that's hard to do, because we all fear rejection, right? And it's hard to say that you have to trust them first, and you do have to trust them first. But in the event that there is rejection, it's tough. It is. It's happened to me, and it's happened to hundreds of other people too. But this is the moment when you find out who your friends really are, because they'll be by your side, right? And you're gonna find out who really, unfortunately, who doesn't care and is only worried about themselves. And it's tough, and but I believe that's what it's called, a life lesson, a valuable life lesson. But yeah, one person at a time.
Yeah, that's beautiful and so real. And I thank you for sharing that. And just, I'm really looking forward to hearing how you all were inspired through this session today and through the whole conference. I do want to let you know that, yes, it has been recorded. It will be uploaded to YouTube. Someone asked specifically if the chat would be available. That will not be available, but the recording will. And we hope you'll come back and listen again, and certainly come to our other conferences this year. We've got more coming. We've got the Strolls for Epilepsy coming. We've got, if you were watching the scrolling PowerPoint earlier, we're going to light up the Allegan Bridge purple for Purple Day. That's on March 26th, and many other things. I just want you to know you can do this work wherever you are, however you are, whoever you are. We tend to think about people that we make kind of big heroes out of certain advocates, but the truth is we all have that capability in small and large ways, and we can do more together than we can do by ourselves. And so that's what's so amazing about building those relationships. Sometimes the advocacy work is building the relationships. And another thing I learned from Adrienne Marie Brown is we move at the speed of trust. I really love that. And when we build that, we can do so much more together than we probably ever imagined. And it's really, really powerful. So I want to thank you, Matthew. I want to thank you, Danielle. I also want to just say I'm sad Janaya was not able to be here today, but she is such a tremendous advocate, and I hope that you all will get to meet her in other settings. Janaya Roberts-Clay, just a really powerhouse young adult who I'm very excited about too. And so we'll be in touch with her and maybe have her another time, but I'm just thrilled that we've had this time together. So I am going to turn it over to Brianna now for our closing remarks. Thank you all for coming. Thank you for making your voices known.